everyone. Good morning. We're going to start with our first session. Our upcoming moderator is Dr. Abdulaziz Abdelbagi. He's a healthcare leader with over 20 years of technical and managerial experience in both public and private, in domains of teaching, regulations, transformation, and insurance. He has a background of medical technologist with American Board of Clinical Pathologists, working on strategic leadership, including regulation, risk, governance, transformation, and customer excellence. Working now as an advisor to His Excellency, the Minister of Health, leading governance of the Global Health Indicator. Please welcome Dr. Abdulaziz Abdelbagi with me, please. Our second moderator, Dr. Bandar Mzahem. He's an emergency medicine consultant, EMS and disaster. He's the EMS medical director and the director of disaster management and emergency dispatch center in Riyadh second health cluster. Please welcome me, Dr. Bandar Mzahem.
Assalamu alaikum. Good morning, everyone. Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah. Welcome for today's session. And with the start, I would like you to welcome and join me and welcome Dr. Fahd Al-Hajjaj. Dr. Fahd Al-Hajjaj is the Vice President of the Saudi Red Crescent Authority, and he's the Incident Commander for Hajj, overseeing the operation for the Saudi Red Crescent Authority during Hajj. He's a trained physician as an emergency doctor and as a disaster and EMS specialist. Please join me, welcome him.
Assalamu alaikum. Sabah al-khair. One of the things that interests me in the past probably 3 or 4 years is the transformation that happens with EMS. I don't have slides. I'm going to talk without slides. There's nothing broken in the monitor. The plan was to speak purely out of experience in the past 3 or 4 years in the season of Hajj. Just to give you an overview of what happens during Hajj, there are a lot of players in terms of healthcare, but there are very few players in EMS provision. And the largest of which is the Saudi Red Crescent Authority. We primarily work as the EMS provider in Al-Hajj, but we do some humanitarian work as well, which includes other activities pertaining to public health and other activities pertaining to the overall experience of the pilgrimage during the trip to Mecca. 90 years ago, when this country first united, there was an issue of healthcare provision during Hajj. And the late King Abdulaziz had a vision of having the service being provided to Hajjis. And the first activity that happened pertaining to healthcare and pre-hospital and out-of-hospital care was his purchase of an ambulance that was gifted to the Saudi Red Crescent Authority to transfer the patients from Al-Haram to Ajiyad Hospital. At that time, it was called the Ambulance Authority, the Ambulance Charity Organization, which then transferred into the Ambulance Authority and then to the Saudi Red Crescent Society and then to the Saudi Red Crescent Authority eventually. So we are rooted as an organization in Hajj, and we are rooted in the EMS provision in Hajj in terms of our activities, in terms of our organizational structure, in terms of our abilities and our experience. But Hajj has changed over the years. And this is one of the points that I want to highlight in this very brief discussion. I believe that the scope of healthcare provision in Hajj has had different targets over the years. So when we started probably in the early 50s and 60s of the last century, the goal was public health. And the goal was to make sure that there is no other cholera that outbreaks in Al-Hajj and then goes to the world, much like what happened in the early years of the century. So that was the goal in the beginning, and the Red Crescent was in the frontier of that, helping with water sanitation and other public health activities, even before the Public Health Authority has been established or the Ministry of Health. And then the focus shifted to have the EMS serve as the provider of out-of-hospital healthcare pertaining to major events. So from the 70s until probably 2000s, Hajj was entered into an era of mass casualty incidents. Started with terrorism, with overcrowding and stampedes, and then the fire, the floods. So all of these events happened, and the shift in focus in the scope of EMS was to make sure that there is enough provision of EMS service for these events. I think we have entered into a new era, probably 2 or 3 years ago, where the focus has been the experience of the pilgrims themselves. And this shift would affect our abilities and our capacity that we spend in Hajj. And more importantly, I think it will affect our scope based on the expectations of the pilgrims themselves. Probably 50 or 60 years ago, it was okay if a patient had a heart attack, that patient will be treated conservatively with the wrist on a chair, because that's what happened in other healthcare facilities at that time. And Mecca had very limited hospitals for its own population, let alone for Hajjis. But I think in this time and this era, we would not expect something less than having the patient taken to a cath lab and having intervention happen to him in a very narrow time frame, and we expect the EMS to be able to do that. So that has affected our ability and our planning and our structure. So that's the first point that I wanted to make. And just to summarize, I think the scope of EMS service has changed, and it has been changing for the past 100 years. And I think it will continue to change. And this will affect not only Hajj and not only the Saudi Red Crescent Authority. I think it's going to impact the overall field of disaster response to mass casualty incidents and the planned events in general. I think we have not spent enough time talking about defining what's the scope and defining what is expected from healthcare in general and what's expected from EMS. The second point that I wanted to make is the provision and the process of service in Hajj. Our approach has been to treat Mina and Arafah as a city, which means we'll have ambulance stations, we will have headquarters in the city, we'll have paramedics stationed in those stations. We expect people to call us, and then we send the ambulance, they pick up the patient, they take him to the hospital. I don't think that's right. I think that would be okay if Hajj was composed of 500,000 people. But if we are talking about the 10 million that is planned for the end of this decade, I don't think that's going to work. We have entered into a race, and we are winning, and hopefully we will win the entire race, where we plan not to receive calls from Hajjis at all. We want to be the ones who indicate that there is a patient, and we want to be the ones who initiate the EMS service. We don't want to wait until the patient has been found by somebody else and then the EMS services have been called. We had an experiment last year where we built lifeguard style podiums where we stationed paramedics on top. They will scout an area of about 100 meters by 100 meters, and they will look for fallen hajis or people who might have an issue pertaining to their health. They will then activate our paramedics. They will go and they will take the patient to the hospital. Our goal was to minimize the phone calls that we receive. We wanted to be there before even somebody called. And as a result, our capacity has to expand to a level where we have enough people to do this. The experience and the experiment worked wonderfully around Al-Rahma Mount, where most of Hajis would go during Arafah Day. We were able to lower our phone calls by probably, I think, 30%, which means 30% of our patients were carried by our paramedics, even without somebody calling in for a patient who has fallen. We have seen the level of sickness of patients go lower because of that, because we have been there first and we have been early intervening with the patient care. I think we will continue to operationalize this experiment and this concept, and I think in probably 2 or 3 years we will have something solidified from a science perspective, from a scientific perspective, to how to provide EMS in mass events that have a lot of people in them in a way that does not interfere with the target of the mass event itself. What do I mean by that? People spend a lot of money coming to Hajj. They probably spend their entire life collecting money to come to Hajj. They don't want to go to the hospital for a wound. They want to go to Al-Jamrah. And they want to be able to throw the stones because this is their mission. Our EMS setup was not geared toward that. Our EMS setup was, if you fall, we come with lights and sirens, we disturb everybody else, we pick you up, we take you to the hospital, probably out of al-masha'ir, henceforth breaking your Hajj, and then taking you to the hospital. We are happy, the hospital is happy, but the patient's not happy. The idea is to shift this, is to change this into a more modern concept that takes into account the expectations of people. So being based as pedestrian first and then vehicle second is something that we are experimenting with. Next year, or probably this year, Hajj, our plan is to be pedestrian first, which means we will have much lower number of ambulances and much higher number of paramedics. The third and last point that I wanted to make was, I think there is a similarity between Hajj response and tactical emergency care. And for the paramedics in the room, we get trained as TECC, so Tactical Emergency Care courses, where we are trained to respond in active shooter kind of scenarios and respond as healthcare providers for the police, helping them recover as much as possible of patients. And TECC, the doctrine of medicine is a little bit different. In a hospital, the doctrine of medicine is to provide all resources to the patient that you are looking at. In disaster, the doctrine of medicine is to provide as much as possible to as much as many people. In TECC, the doctrine of medicine is medicine comes second, does not come first. First is the mission. The mission has to be completed. I think there is similarity in Hajj as well. And this is evidenced by the demand of our patients signing off from hospitals or going against medical advice to go and complete their Hajj. And I think this has to be taken into account. It has to be accounted for in our planning for the Hajj in general. I will end up with one story. I was working in one of the hospitals in Hajj, and a patient came in. He looked very pale, and he was in a gurney with a lot of cotton in his abdomen. So I asked him, what happened? Apparently this patient had an umbilical hernia, that umbilical hernia incarcerated in the early days of Hajj, probably the first or second day of the Hajj. He went to one of the excellent hospitals in Mecca. They did a very excellent procedure where they repaired his wound and they repaired his hernia. And then they put him in the ward. And he was supposed to recover for about 2 weeks and then go back. Patient signed against medical advice, left the hospital, went straight to Jabal Rahmah, to Mount Rahmah, climbed the mount, prayed, came down, his wound opened, and his intestine are out. So they carried him and they brought him to the hospital. He was happy. He completed his Hajj. I think this has to be accounted for in our Hajj healthcare planning, is that the mission comes first for the patient. And if you want the patient to be satisfied, then this has to be implemented in your plans, either AMS or otherwise. And with that, thank you very much for listening.
Donahoe. Dr. Don Donahoe is a professor of global health with the University of Maryland, Baltimore, and he's working as a president of the World Association of Disaster and Emergency Medicine. Professor Donahoe holds a concurrent appointment as a faculty with Harvard Medical Physician, as a senior researcher with the Sigmund Freud University in Vienna, Austria. He's a former professor, program chair, graduate healthcare administration, and global healthcare at the University of Maryland Global Campus, deputy surgeon for the U.S. Army Reserve, and board chair for Melwood, a disability service agency. Dr. Donahoe's experience includes work in primary care, behavioral health, home care, workforce health, lobbying and consulting, and global healthcare administration, including corporate consulting and departmental leadership in a major urban medical centers. Please join me in welcome Dr. Donahoe. I hope I mentioned your name. Thank you, sir.
Thank you. As you now have heard my entire CV, so I thank you so much. I have to say, actually, that last anecdote that was mentioned about the patient at Hajj. It could not have been a better intro to what I'm going to talk about. Is the behavioral aspect of disaster medicine. Yep. Got to do it here. Oh, okay. Here we go. So we always start in the U.S. with, I'm not getting paid to do this. So human element. So often, I mean, I'm not going to read this slide, but often what we plan for, we talk about material, we talk about the facility, we talk about IT. We often overlook the individual, the people. And the second bullet is from a colleague in the U.S. where they have a saying, it's actually the motto of their company, that every crisis is a human crisis. If you remove humans from the equation, then it's not a crisis, it's not an issue. And I found this great quote as I was preparing for this from 1999. But basically, it says when we plan things, we talk about the structure and the environment. The people who actually are on the site who manage the event, they worry about the people, not so much the surroundings, but the people. So they have different perspectives, as I said. Planners usually look at the environment, the buildings, the pathways. They look at the technology, the signage, the signage, the IT, the lighting. The people in the field look at the people. What's the process of what's happening where they are? So we really, if we're going to practice effectively for mass gatherings, we need to merge those two together so we have a comprehensive approach. Planning factors, we look at weather, how long is the event, whether you're indoors or outdoors, the crowd, how they are, whether the site, whether it's fenced in or open, all of those things, the crowd mood, crowd density, and how old they are. So what we tend not to look at again is the human element. So there's a great reference, socio-technical approach. So we always talk about goals. We talk less about people. Buildings and infrastructure, technology, again, culture. You know, the culture, the anecdote, the culture of doing something that's required, you know, to your faith, and you're not going to let something like an injury get in your way. I think that was a powerful testimony to the role of culture. What are the processes and what are the procedures that we follow? So, understanding the population is important. I found a great example of a sports stadium disaster in the UK and England, where fatal crush at a football match way back in '89, 97 people died and 776 were injured. Part of it was poor stadium design and poor crowd control, but the investigation that occurred after the event determined that the biggest problem was because of things that were going on. The crowd was frustrated and they were angry. And when they started acting out as a frustrated and angry crowd, the authorities, the police and the medical system looked and said, you know, using the British term, they were hooligans, they were troublemakers. They failed to realize that what was driving the crowd to act the way it did was the environment and their personalities, that they were human, not what the authorities assumed. So you look at triggers. What can cause a crowd, a mass gathering, to go wrong? Fire, obviously. Emotional instability, if there's fighting, if there's two factors. In football, that's not uncommon in parts of the world where one team and the other team will start fighting each other. The fans. Fear, you fear of being hurt. Anger, violence, rage. Spatial limitations, again, you know, the number of people appropriate for the space you're in. And it isn't necessarily a bad, negative event. Almost a year ago in Seoul, Korea, there was a crushing incident where people were celebrating Halloween, and there were too many people in a closed environment, and they were literally crushed by the crowd. You know, people standing in the middle of the crowd, crushed to death. You know, so this was a happy occasion. It was a celebration, yet it turned tragic. And then again, the demographics. What are your beliefs? Do you have deep-seated political beliefs, religious beliefs? Deep beliefs? Do you relate to a certain team or a certain nationality? All of those things drive human behavior. So, some tools, though, and I won't talk for another day about this, getting into human behavior, but there are some tools that I would recommend. First is, coming out of Australia, ramp analysis. I thought this was really simple. You look at the routes, the areas, the movement of people and their profiles. Planning in ahead, the routes are easy. You create a map out the area, make a graphic representation that allows you to see things that you might not identify looking at the environment. Show where the crowd's going to be, how they're going to flow, how they're going to move around. Where are they going to enter? The transport hubs, how are they going to get there, how are they going to get out? Color-coded so you can see exactly what's the high-density places, what's the low-density routes, so you get a feeling for what you're going to be facing. How is your area How is your area planned out? Is everybody going to be in a large common location, or are they going to be, in some cases, in music festivals, they'll have multiple stages. How do people flow from one side to the other? What events trigger them to go in those places? All of that, and again, the color coding is really a powerful visual tool. Green means you're probably not going to have a problem. At the other end, red means this is an area that's a challenge. This is an area where you might wind up having a catastrophe. Track the movement of people. When will they show? If people are arriving by mass transit, what time do the trains show up? When do they leave? Projecting and being able to project graphically where people are going to be, when they're going to be. And then again, look at the people, look at the profile. Historically, what has happened? What type of crowd is going to be expected? What's the focus of the event? Is it a celebration? Is it a celebration? Is it a religious event? Is it a protest? All of those things will factor in to how your crowd's going to react and how they may react. I offer a thing called the Haddon Matrix. Haddon was an engineer in the U.S. Department of Transportation, and he developed this matrix, 3x3, of how to plan for different events in automobile safety, how to analyze traffic accidents and the deaths. It's really applicable to mass gathering medicine. Like, look at the factors that relate to the personal behavior, look at the things that affect that behavior, and look at the environment, and you can project out what your high value, high probability scenarios are. That can be expanded. I found a great reference that talks about expanding it into three-dimensional. So dimension one, again, is the event characteristics. Where are you? What's happening? What's the physical environment? The second dynamic is the event, what's going to happen before, what's going to happen during, what's going to happen after. Then you lay in a third dimension, which is the innovation to the original model, is what are the value criteria? What are the things that will influence? What are the beliefs that will make a difference? You assign weights to each of those aspects, give it a weighted value, and fill in everything, and that gives you a listing of where your priorities are, where your major concerns are. And finally, look at each criterion, analyze and plan accordingly. And then at the end, document it, see what went right, see what went wrong, so you have truly lessons learned and you can come up with decisions for the next cycle around. There's another two more models. One, this actually shows the psychosocial, the biomedical, and the environmental domain. The psychosocial, they are in increasing order of how well we recognize them. We usually get the environmental down. We understand biomedical. If it's hot, we understand that people are going to need water. Things are going to happen. The psychosocial, though, we often miss. We also don't think. So it delineates how these factors interact with each other and how they drive. And then finally, Ranieri in 2013 took all of these things that I just spoke about and put them in sort of a flow chart where it goes back and forth, and ultimately comes down at the upper right is how your crowd behaves, how they believe, what they're going to do, that determines how the planning is and the part that we need to pay better attention to. So I also recommend with AI and technology now to consider augmentative technology. There's actually a trend now where you can monitor a crowd and you can look for anomalies in their behavior. When they do something, it's an indicator that something else is going to happen. So it attracts 4 phases: the density, motion detection, tracking, and the understanding of the behavior. Last but not least, understand and anticipate behavior as you're planning your logistics. Gaps that you have can result in adverse outcomes. That's why we're all here. And ultimately, it was found that when their physiological needs are met, but their psychological needs aren't met, that undermines people's faith in the institution and the event and the leadership. So it has a long-term impact. And ultimately, the great Canadian author, human nature is not obliged to be consistent. Never, always expect the unexpected. Some random references that support this. Oops. My contact information. Thank you very much.
Presentation. Our next speaker is Dr. Jamie Rance. Dr. Jamie Rance, he is an associate professor. He's recognized for his work first on the strength of the health system for disruptive events such as disaster or mass gathering. Dr. Jamie is a chair of the Mass Gathering, a special interest group of the World Association for Disaster and Emergency Medicine. Please welcome Dr. Rance.
Thank you very much, and thank you for the opportunity to come and speak with you all today. So as a bit of background, and we don't need too much explanation about this, but we know that mass gatherings occur at various locations globally. We know that these differ in types of event typology, and these things influence the way in which we therefore need to provide health services at these mass gatherings. But what kinds of interventions should we be doing at mass gatherings that might improve the health outcomes for people attending those events or in the local community? And perhaps to some degree, the idea about health outcomes at major events or mass gatherings hasn't been thought about in great detail. So I think it's about two things. One is about ensuring that we've got adequate health and well-being of those people that are attending the event. We know that there is increased risk for those people attending an event, partly because it's harder to get some egress or access into the event itself to provide a health service if need be. So the health and well-being of people at the event. But of equal importance too is to ensure that we have adequate health service provision still in the communities surrounding that particular event. That is, if there's an event held within a particular community, we should be able to expect from that community the same kind of response time and health outcomes, whether there be an event there or not. So how do we put in place interventions which limit the impact on our local health services so that they can maintain their normal operational capacity? And that goes back to some of the conversation we heard from our first speaker about enhancing EMS services perhaps to ensure that the health services are not overwhelmed by numerous calls. So interventions in event health services, I've already mentioned that they differ a little bit, and that is partly due to the governance structures which are in place and the various diversity of models that exist. If we look globally around the models of health services at events, they differ quite significantly. Here, though, we notice a couple of key things in the literature about the movement of governance models, and that is, a while back, health service provision at mass gatherings was undertaken by lay people, first aiders, doctors, nurses or paramedics who had some goodwill and wanting to help out to protect those people attending an event. But what we start to see now globally is more governance structures in place to support health service provision at major events. So moving less from goodwill and more towards structured health service provision approaches. These health services are a combination of two things, and many others, but two things in particular: health resources or physical resources. So I'm going to draw on some of the literature now that talks about how we provide interventions, being health services or physical resources at mass gathering events. And from the human resource perspective, we often have first aiders. And along the bottom you'll see a diagram which represents a clinical hierarchy of care at mass gatherings. So first aiders are often lay people who have a first aid certificate. They might have another job as a full-time job and come out to help on weekends or during major events to provide a health service. They often have a limited scope of practice because they're not trained healthcare professionals, and often, sometimes, they will work under the direction of a healthcare professional at a particular event. Then at the event itself, we might have healthcare professionals who are deployed to that event, again to minimise the disruption to the community and also to provide an adequate health service at the event itself. This can include doctors, nurses and paramedics, traditionally. And as now we look further into the literature, we see the emergence of other types of health professionals at these events as well. And the list is starting to get quite extensive about the multidisciplinary team of people who are contributing to the health and wellness at events. Ambulance services, EMS, often have on-site support, and as a result of that has a human resource element to it. And the human resource element comes from two aspects, either a designated on-site ambulance service or sometimes ambulances which are in the local community as extra surge who will respond to the particular event. And lastly, around the external health services, and that is the local hospitals. And whether or not hospitals are built for a particular event or whether there's additional staff at those events and staffed at hospitals where those events are being held. So human resources is kind of a bit black and white about how we can employ human resources, but human resources have a cost to them. It takes time. Obviously you need to employ people and credential and so forth to make that happen. Other kinds of interventions you could have at a major event or a mass gathering would be around physical resources. So, again, as a first responder or a layperson, these might just be simple things which you could train people to use, simple analgesia, undertaking a set of normal vital signs, teaching them what is normal versus what is abnormal, and then if something falls into the abnormal, to be escalating that particular care to somebody else. That care might be the local EMS, or it might be if there's on-site doctors, nurses, paramedics, or a large list of those other healthcare professionals to one of those persons. But where we're seeing a large shift in interventions is through healthcare professionals at mass gatherings and the integration of technology, which has predominantly been hospital-based technology, then moves into the EMS or ambulance service sphere, and is now making its way into the mass gathering space as well. This can include lots of point-of-care testing, so we're seeing lots of point-of-care testing at mass gatherings, including point-of-care ultrasounds, bloods, whether that be EPOC or otherwise types of testings. Through COVID, we saw a lot more around the transportality of point-of-care testing for PCR-type swabs, and we're starting to see an increase in medical imaging types of interventions as well, particularly in EMS with ambulances that may have CT scanning capability, the ability to do ECMO on the side of the road, and so forth. So, again, these would be nice interventions to have at a mass gathering, right? But what's the likelihood of needing such a thing? How will improve patient outcomes, and how much does it cost to have at a particular event? So these are some considerations when thinking about your mass gathering event. Obviously, we're seeing a larger array of medications being used at mass gatherings as well, particularly with on-site pharmacy and an array of medical physicians on site. And also we're seeing a diverse array of skill mix. So traditionally it might be emergency medicine type physicians that were attending mass gatherings. Now we're seeing a larger array, mental health, primary health, community health type physicians as well. And as a result, the skill mix of the kinds of people we see can change. Now, depending on the risk of your mass gathering, might determine what kind of intervention you want to have here in terms of the skill mix of the person. So then you decide, well, we might have a particular person that we need with a particular skill mix, but where do they come from? And often you're drawing them from places of high demand anyway, such as your local hospital or ambulance services. So there's a balance between whether or not we place people at an event to try and help people at the event itself, or whether or not we're better off having people back in the health service, in the hospitals or in the ambulance services in the community to provide both services to that event itself, but also the broader community at the same time. I mentioned briefly some aspects around EMS, an ambulance doing now portable x-rays and CT scans and ECMO. There's lots of examples now, particularly in the stroke sphere around people accessing these types of resources on the road, and how these might be played out in the mass gathering space as well. And finally, back into the hospitals and how these integrate within your mass gathering, having an understanding of the risk assessment, where they lie, and what level of service they can provide. So to finish up a brief discussion, you need to have some governance structures in place to ensure that whatever intervention you implement has adequate training support, is patient-focused in mind, both for those people attending the event and within the community itself. There's lots of things that we can do. Doesn't mean that we should do, just because we can. Innovation, well, what's next? As I said, we're starting to see shifts of things in hospitals becoming more transportable in the out-of-hospital space. I think we'll start to see some shifts in how that might look like into the mass gathering space as well. And finally, around the cost and the cost benefit. So if we have a mass gathering where we have no interventions at all, the cost is very small. The benefit to the community is not very good, because it's likely that there'll be poor outcomes. So the commentary would be, well, how much do you put in place in terms of human and physical resource? How much do they cost? How much benefit do you gain in terms of patient outcomes from that? And then cost aside, maybe it doesn't matter so much if we're focused on patient outcomes. I don't know many health services that actually make any money, so maybe it's more about providing adequate health services to people at these events to give them a good experience so that they can return to the event itself. Thank you for your time. Thank you.
Speaker is Dr. Mubarak Al-Mulhim. Dr. Mubarak Al-Mulhim, he is a senior consultant physician and Canadian certified emergency critical care physician focused on patient-centered and outcome-based and values-based healthcare. He has an extensive experience in senior academic program directorship and senior management roles in various healthcare organizations. Dr. Mulhim is an expert in disaster and crisis management and has demonstrated leadership in COVID-19 response in Saudi Arabia, and he's also have a major role during Saudi health preparedness for World Cup 2022. He is actively involved in the transformation initiatives in Eastern Health Cluster. Please welcome Dr. Mulhim.
Assalamu alaikum. Good morning, everybody. Mr. Chairman, it's a great pleasure to be here amongst the experts elite in the podium. I'm afraid I'm going to take more time, but because of the miscalculation of the time allowed, but it's mostly visual. This is just a storytelling about what we have first as an experience in the Eastern Province when preparing for the World Cup. People ask why in the Eastern Province, and that's why I'm sharing this with you. So we'll just go quickly about the outline. I'll try not to bore you with some of the content, but I'll just take you through how did we do it, how did we plan, how did we integrate, and how did the health transformation in Saudi Arabia actually helped us in achieving that kind of mission. And this is kind of the flavor. I'm not going to tell you about the World Cup. We all know how extensive is this and how mega mass gathering it is. We are not in a position to talk about it like the Qatari, but we, in the Eastern Province, we have reason to be prepared for this sport event. And this sport event of World Cup, we have to consider it as a public health emergency. It's not like a disaster that will happen over a day or two, but it is an ongoing stress to the community, to the public health, to the resources that will last for some time, that require a lot of preparedness. Why in the Eastern Province? As you know, the Eastern Province is the largest area or region in the kingdom. We are the only border for Qatar, and a lot of travelers during the World Cup will go through the Eastern Province. And that kind of put us on the front line to be ready to receive a lot of mass casualties in terms of MVAs. And you know the fact about MVA in Saudi Arabia. And the Eastern Province oversees 8 ports. So we have from Kuwait north down to Oman, Bahrain, Qatar, we have airports. So all these are ports of entry into the Eastern Province that feed in Doha. That's why we needed to be prepared. This is just to show you the yellow area. These are the ports of entry where we have travelers expected to cross the Eastern Province to Doha. So we expected about 18 to 27 flight travelers, but we expected almost 10 to 23,000 car travelers through the Eastern Province on top of our usual traffic. This is how bad it is. So we need to be prepared. We need to have preventive measure, therapeutic measure, response to medical emergency, and this is how we wanted to integrate. As I said, this is a public health emergency, so we need to ensure that we fulfill all the domains of public health emergency. So we need to have a resilient community, we need to have an incident command, we need to have an information system. We have to gather enough information, and we need to have mitigations, and we need to be prepared to manage the surge. And of course, we have to be active in terms of biosurveillance, of course, coming out of the COVID, that was a major issue. In the usual disaster, this is the common, you do preparedness, you response, you recover, you mitigate, and this is a cycle. In this public health emergency, it's more than this. So you do the risk assessment, you do public health preparedness, you do medical preparedness, you do risk mitigation, you establish an incident command, and you do a lot of emergency response, and this is a bigger cycle. And of course, we apply in this cycle all the requirement of the 6th domain of the public health emergency. So being resilient, doing biosurveillance, integrating all the data and information we get from Qatar, from the Emergency Operations Center in Riyadh, and also integrating it into an incident command. And of course, eventually, we need to work on. So this is the risk that is usually faced on in a World Cup. I'm not going to bore you with it, but it is very common that you see, based on the history and based on the preparedness for Qatar. Of course, COVID was a big issue. Collapse of a stadium, terror attack, food poisoning, fire outbreak, psychological issues, robbery, and you go down the list. And we know in each particular mass gathering event, be it religious, be it sport, we know the common injury based on limited actually studies. And so we had to do our own risk assessment, and based on our own risk assessment done collaboratively between all participating sectors, we came up with this list of 12 top emergency, of course, in line with the Kingdom Emergency Operations Center and the Kingdom Command and Control. We did some mitigations for the top priority. As you know, based on us in the Eastern Province facing the major traffic, it's going to be mainly MVAs, and of course, this is the biggest mitigation. Of course, we have Dr. Fahad is here. Red Crescent is facing this as, of course, responder, but also we will face the challenge as a hospital preparedness and inter-facility transport. So we tried to prepare for this. And of course, when we looked at it, so we did the risk assessment, then we look at the profile of being prepared. So this is really a very important profile that we wanted to address. So at the port of entry, we need to be ready. We need people to be there. We need to educate them, train them about dealing with infectious disease, with challenges, mass gathering at the border, and of course the road traffic safety. And believe it or not, the road traffic safety was so good during the World Cup that we have seen actually less motor vehicle accident than usual. Actually, the number was actually low because we have a lot of police enforcement, and of course, Sahir was very active and installed in many additional areas. Of course, we did a pre-hospital. We cooperated with the Dr. Fahad team, the Red Crescent. They did a great job. They dispatched helicopters, and they kind of facilitated many helipads area. And we had the only single facility, which is a small hospital. It's called Salwa Hospital. This is the hospital next to the border. It's only 50-bed hospital, very limited. It's a very rural hospital, very limited resources. So how can we build it up to become an emergency and critical care hospital? We, of course, work together with public health and infection control, and of course, we have to have an actual active operation and command, and we were happy that the Kingdom is already accelerating in this system where we have an emergency operation command at the Kingdom that we integrate with. This is very good example of joint command. So we had a very beautiful alignment between the Ministry of Health, other health sectors, Red Crescent, also the national and also regional incorporation within the command area. We had daily reports, we had daily surveillance, we had daily data flow in order to manage. And we also looked at the road. The road was very important. We mapped all the road to make sure we know which rural hospital will be affected and how can we manage the inter-facility transport in collaboration with the Red Crescent when they respond to the scene. We have studied the pattern of flow, so we know which day we expect to have the highest flow. As you know, during the Saudi soccer game, we expected massive flow of massive flow of cars. So you can see during the days where the Saudi team will playing, so you'll have the peak, so we got to be prepared, and we have to mobilize our resources. As the World Cup move toward the end, we're seeing less and less flow. And this is a kind of statistic where we had almost at the end, we had about 4 million cross the border during that 3 to 4 weeks period. But it was very useful data where we have Ministry of Transportation data, we have Ministry of Health data, all integrated into one system through the emergency command at Riyadh, and of course helped us in providing the enough preparedness. The port of entry at Doha, which is Salwa, was really let's say the activity is, because there we need to mobilize manpower, we do specialized training, we have to implement the WHO and hosting the country mandate, because Qatar, through FIFA, they have a lot of mandates that we have to fulfill. And of course, providing COVID testing as a backup for people who are not tested, and the BBB. And of course, we actually initiated the trigger warning area in the port of entry, so that any mass gathering issue or challenges or blockage of the border, this is where we initiate our command. This is the pre-hospital response. This is just to represent the Red Crescent, what they have done, wonderful job. They have all their volunteers, their air ambulance, their Red Crescent cars, the fleet, and also the manpower. Was really tremendous work that we have to congratulate them for. We did a lot of drill. We established a lot of helipads to make sure we fulfill the requirement of the Medivac. And also we started to look at our hospitals. How prepared are the hospitals? And you know, through the HIPPO, or the Hospital Emergency Preparedness Unit, in every hospital, they have to do deep dive assessment, how ready they are, they have to do drills, they have to make sure they have a proper medical evacuation, and of course they have to focus on emergency, critical care, and surgical intervention. This is the representation of the small hospital across the border. It's a very small hospital, it's a rural hospital, it's only 50-bed hospital, where we have a small ER, mainly primary care, no OR, no ICU, no CT scan. So we need to make sure we fulfill all this data, all this kind of requirement. And it's just like next to the border. This is where all the traffic, and of course, many other traffics coming from UAE, from Oman, and from Riyadh, they come through this area. So we were happy to have the Ministry of Health a small, let's say, field hospital established. It's another 50-bed field hospital with the Red Crescent involvement, and with our interfacility transport to make sure all these patients go to the right, after being resuscitated, to go to the right location. We established a hotline, an emergency operations center within that small hospital, because it was our trigger zone in the area. This is how we remodeled the hospital, in a way that we kind of converted to a complete emergency and critical care hospital. So I know it took me too long, but this is a lot of work, a lot of preparedness. This is the map that I'm proud of that we have done, and applying the ramp that Dr. Donald have kind of mentioned. This is the route, this is the area, this is the movement, and this is the behavior. So we mapped out all the routes of the port of entry. We mapped out our collaborating hospital, the helipads, and of course the transport system. This is the hot zone area. This is the interfacility transport that we have customized ourselves in the Eastern Province, which was helping very well. It's electronic, and it's of course the communication system that is tracking our population. Again, we had a special thing that we did. We had a field hospital that we have discussed through the Saudi REMAT. We had a rapid response team to respond to any team to support the on-scene team, and of course the mobile trauma. So we had a mobile trauma team that go and help any rural hospital, and we have the virtual health that is supporting us. That's the kind of thing we have in the Eastern Province. I'm sorry it took me too long to describe it, but we had a lot of challenges. It was a really great opportunity. We experienced disaster medicine, public health, and it was a wonderful experience that we are glad of. Thank you so much.
Experience, so we're glad that you presented to us. Our next speaker is Mr. Imad Al-Zahrani. Mr. Imad Al-Zahrani is the Regional Director of Operations for the Western section at NIPCO. He holds the master degree in the supply chain management and logistics services from University of Brighton in UK. Please welcome Dr. Mr. Imadun.
Assalamu alaikum wa rahmatullah. First of all, thanks for having me here. Okay, let me start. Slide. Shall I point here? Let's start. Is it with me? Okay, today I will be talking about logistic challenges and solution, but hopefully it's okay. That's fine. ما في شيء ما هي مشكلة. I have the slides. It's okay. It's okay. والخط. Okay, we will start until they fix something here. We have small issue here. Hopefully we can fix it now. I will start actually, I want to explain to who doesn't know what is NOVCO actually. NOVCO, it's a company. It's owned by BIF, and it's responsible to supply all medical supply to all hospitals. And one of the, let's say, the area that we serve it's Hajj. So we have actually served the Hajj for the last 3 years. We started that for the last 3 years actually. Okay, I will start with the challenges. We can, it's okay now? I will start with the challenges. Actually, we divide the challenges in two sides. Actually, we have challenges before Hajj start, and we have challenges during the Hajj. Before the Hajj, we have, I think, the common challenge and let's say the complexity of demand for the forecasting. That's impact actually our availability in the hospital. We go actually with our colleagues in Makkah cluster and we ask them about the needs. This is what we have done every year actually. They share with us their need and we start preparing 6 months before. Unfortunately, sometimes we cannot provide some items due to some, let's say, challenges. And those challenges, it's come from outside and some from the, let's say, manufacturing or from the supplier. We think the lack of supply chain feasibility and the seasonal variation and the changes of the end user demand is the main reason that's impact the complexity of demand and forecasting. Also, some logistic company now they're facing increasing in the warehousing and operational costs. This increase in the costs, let's say, this increase in the costs makes the company didn't provide the items on time because increase of the holding costs in the warehousing. This is, let's say, get some of the profit margin of the company, and they cannot hold all the items that we needed. Also, we face shortage of raw material due to, let's say, external and internal government regulation change, and also some events such Ukraine war. I don't want to focus actually mainly on the challenges. I want to go directly to the solution, what we have done actually in, let's say, previous years, and what we can do in the future. We believe that using artificial intelligence can improve our forecast on the demand as we have huge data. This can also give us better optimization for inventory better optimization for, let's say, our fleet, and minimizing the timing of, let's say, delivering the material before Hajj and inside the Hajj. And I think the most complicated issue during Hajj is how to fulfill the needs, actually, how we can respond within a few hours to the needs or if there is any disaster. We started actually using, let's say, some technology in the past in some hospital, and we think applying those technology during Hajj season will improve our service. Like one of the example, it's using radio frequency identification, RFID. This technology can enhance the accuracy and increase the efficiency and improve the visibility. It can give us the real-time monitoring. Okay, some hospitals now, I think they are using the smart cabinets inside Saudi Arabia for the, let's say, critical item, for the cath lab items, a guide wire, pacemaker or something, in order to make sure they have it on time, they can control the inventory. And this also reduces the timing for ordering and booking process. Last years, we have, let's say, a good experience. We tried to use scooter during Hajj, actually. And we found that using the small, let's say, ambulance or truck and using a scooter, it's actually improve our service. So we start thinking of, let's say, can we use the drones for next years? And we put this in the table, and we are in discussion now. Is it possible to use the drones during Hajj in order to serve the hospital? Also, we have experience now. We're handling one of the biggest warehouse in Middle East, in King Abdullah Medical City. It's fully automated warehouse. And this warehouse, it's now can store more than 100,000 pallets. And we saw that the experience with using, let's say, automation warehouse, it was actually providing better inventory management for us and efficiency in picking process. So we're thinking of using warehouse robotic in the future. In conclusion, I want to conclude with something. I think more investment in technology can, let's say, improve our service and reduce the cost and improve the satisfaction for the customer. Thank you.
Thank you for their very informative presentations. Now we want to open the floor for interaction, questions or comments from our audience. تفضل تفضل.
I am Dr. Ahmed Al-Ghamdi from Jamiat Qura. I would like to ask the experts, is there any degree worldwide on mass gathering? This is a special question for experts. And the other question, as our country is a leader in all the facilities and all the medical care, is it the time to establish a fellowship or a baccalaureate program or a diploma program in mass gathering medicine? Should it be for subspecialty for emergency consultants or for all medical field careers? Thank you.
Thank you for that question. The education and training of healthcare professionals to work in the mass gathering context is of importance, I think, particularly because, as I mentioned previously, not necessarily many people have experience of working in the out-of-hospital context during a mass gathering event. So whilst we might have the appropriate clinical skills, knowledge and attributes to work in the in-hospital context, to translate that into the out-of-hospital environment, and particularly in the out-of-hospital environment during a major event, is very different. So whether or not that is formalised into a fellowship, it's probably an in-country decision, but there's definitely some type of need to recognise some subspecialty training for mass gathering events.
I would also add I walked through the exhibit hall earlier today, and one of the booths is the Eastern Mediterranean Regional Office of WHO. And I know that the East EMRO, one of their high priorities is developing internal capabilities for all the nations within the region. I think there's, if I remember correctly, it is within all of the countries here, there's 3 emergency medical teams certified and trained. So that's a really good resource for learning the skills, getting certified, and developing the internal capabilities, but also learning what your neighbors, the discussion about the cross-border travel with the World Cup. That was a great example of 2 nations working together to enhance their capabilities.
No.
Okay, any other question, please?
Good morning, everyone. Thank you for a wonderful session. Sorry, I missed the first part. And I have a question for Mr. Imad al-Zahrani from NOPCO. I think he was very humble when he mentioned their last experience in Hajj, because firsthand we've experienced with them the amount of work they do during Hajj. And I want him to shed the light on the idea of having digitalized or fully digitalized their houseware, and the new idea of having satellite and mobile warehouse for immediate deployment for any possible and anticipated shortage in the supplies, because we've experienced it in Hajj. He mentioned that they responded in hours. I think he was very humble. In like less than 40 minutes or 30 minutes, they were able to deliver what's requested from certain hospital and field hospitals.
Thank you. Actually, yes. Last year we implement our system. Actually, we extend our system to all the, let's say, BHC and hospitals, and we ask all the end user to use the handheld. It was linked with our dashboard, actually. So we have command center. We have the team over there. Once they reach the reorder point, by default, he doesn't need to order anything. We directly to deliver them. We have 3 actually centers to deliver. We have deliver from Arafat actually, and also we have deliver from Mina, and sometimes we deliver from other hospital in order to serve the hospital immediately. Then we can fulfill the hospital again.
Any other question?
Yes, thank you for the informative presentations and talks. And I have 3 questions for 3 speakers. And so the first question is for Dr. Al-Hajjaj. So from your opinion and point of view, what has changed over the years in the scope of practice of the EMS, especially in a mass gathering event like Al-Hajj? Yeah, so this is the first question. If I don't know if you would like to answer it one by one or just.
Look at one by one.
Okay.
Thank you for the question. I think the issue of scope practice for out of hospital providers started with cardiac arrest and cardiac care, where we decided that ambulance drivers should be able to do CPR and should be able to do something about patients who are dying from cardiac arrest. I think this is still evolving, and we are seeing a lot of technology and a lot of activities that happen inside hospitals being adopted by out-of-hospital providers. And case in point, the presentation we heard about from our colleague from Australia, where he started using ultrasound. Some people are using CTs, and even at some point they might even use MRIs and ambulances. So who knows? Maybe we will reach the point where out-of-hospital providers would have further scope in these technologies and testing and other technology. I think it mirrors what happens with medicine, where we started as general practitioners and now We have a lot of experience and a lot of subspecialization. I think out-of-hospital medicine in general is still evolving, and we have not reached the point yet where we say this is the limits of out-of-hospital care and this is the limits of in-hospital care. I think it's still moving. I don't know when it's going to stop, but I think it's a very healthy discussion that happens every year where we review what we are going to do as out-of-hospital. I just want to add one point, if you allow me, that especially in mass gathering and especially in Hajj, the line between out-of-hospital and in-hospital gets moved a little bit, where we include a lot of activities in out-of-hospital, because a lot of, again, the mission, the primary goal is to complete the mission. People want to complete their Hajj. So maybe we should train our paramedics to do some simple suturing, some other interventions that not necessarily need to go to the hospital for. And we work with patients and developing something that makes sense to them and makes sense to our paramedics and makes sense to our medical directors who review the information.
Thank you for everyone. Because of the time, I think we are run of the time.
So one question, another question for Dr. Donald, if you allow me, please.
You can choose one of your two questions, and it will be the last question.
Okay.
Thank you.
So for Dr. Donald, what advice would you recommend for gaining better understanding for a culture for people attending attending an event?
I think, and actually I had a comment for you too, but I'll come back to that. One of the challenges globally is we tend, each discipline, each profession, we tend to work in our own silo, in our own area. And I use an example, it's not mass gathering, but in 2014, when the Ebola crisis was in Western Africa, at the time I opined that it's not a clinical crisis, because as horrible as Ebola is, we know what to do with it. It was a cultural anthropology crisis. We needed to have people in who understood what the people in West Africa have been doing for generations, how they deal with the sick, how they deal with the dead. And we needed to change those practices in a way that honored their culture, wasn't offensive to them, that would allow the disease to become, get under control. So I think it's the same thing, involve people who are experts in behavioral health, sociologists, and include them in the planning. And actually my other thought, I think for EMS, your first question, I think the biggest challenge is it's gotten more complicated. As Dr. Rand said, there's equipment, there's technology, everything's changing, and in most of the world, I'm not sure here in Saudi Arabia, but in most of the world, EMSs, emergency medical services are getting smaller. They're having trouble recruiting people. So I'm having fewer people dealing with more technology, and what's been found in military is the farther forward, using the term, the farther forward I can treat someone, the higher the survivability rate is. So how do we get that capability farther towards the point of injury? I think that's the largest challenge.
Thank you.
Thank you, everyone. We will start after maybe 10 minutes with the next theme.
Thank you all for your questions. Now for the group photos. We will take 15 minutes coffee break. We will be back at 10:35.
Ladies and gentlemen, please join me in welcoming our second session moderators, Dr. Bandar Al-Mutairi, Disaster and EMS Fellowship from Brown University, Master of Business Administration, in International Healthcare Management from Frankfurt, Head of Emergency Department at the Presidency of State Security in Saudi Arabia, Consultant of Emergency Medicine at King Fahd Medical City. And please welcome Dr. Abdurrahman Sabah, Consultant Emergency Medicine, Medical Education and Simulation from Harvard, Boston, MBA in Sport Management and Assistant Professor at Al Faisal University. Chairman of Simulation and Education Department at Riyadh Second Health Cluster, Consultant at the Global Center for Mass Gathering Medicine and Medical Director for Sports Events.
Thank you. Assalamu alaikum. Good morning, everybody. It's my pleasure to introduce Prof. Majid Al-Salama. He's Chairman and Department of Emergency Medicine at King Abdulaziz Medical City in Riyadh. Previously held position at Chair Scientific Council of Emergency Medicine at Saudi Commission for Health Specialty from 2017 to 2022. Also was at Dean College of Public Health and Health Informatics at King Saud bin Abdulaziz University for Health Science for 7 years. We are honored to have Dr. Prof. Salama here today, and I'm sure his insight and expertise will enrich our knowledge. And please join me in giving a warm welcome to Prof. Salama.
Thank you all. It's a pleasure for me to come up and meet with everyone. And my presentation is going to be probably an introduction to this excellent session. And looking at the names coming after me, I'm glad I'm the first one talking. So with that, I'd like to start. I'm just going to give a little bit of background on why this is an important topic in our country. Give a little bit of background on some of the guidelines that came out and mitigation strategies, and hopefully by the end we can recommend some future research to be done. Sorry. So we live in a dry and hot country, so if you look at our background, we as indigenous people of the region, we're probably used to having hot climate in general. You see it in our clothing ever since in the long past. We always cover our heads. It's a shade that's moving with you. You wear light clothing, and it should be aerated. It allows air to come in and out. And if you're rich, you can actually buy some cotton clothing back in the days. And most of us now, we know that cotton clothing is probably the best thing you're going to be wearing for the summertime because of how much air it allows in and how cool it gets. But in general, our problem is when people come in from outside the nation, and being that they're not used to the heat and weather, we start facing problems. This is a picture of the 2015 Mina Stampede. Now, although they call it the Stampede back then, it was really a mass gathering incident of a different type of injury. It was mostly heat illness. These people, when they gathered for Hajj, this was on the day of Eid, and these large numbers of people were trying to get to the Jamarat region, and they clashed in one specific area. Now, according to the planned route, they were not supposed to clash in that area, but it seems that There were specific populations from specific countries that decided to go out on their own time and at their own term. So what happened was people started crowding up in large numbers, and this was midday. It was September, and due to this huge number of people crowding together, people were not able to regulate their temperatures anymore. And as if you can see from the previous slide, this is aftermath. This was not during the crowding. This was when they were picking up patients afterwards. And what happened was the penguin effect. So we all know that penguins, they gather together to cope up heat, even in the worst, coldest environments, and they're able to keep their young extremely well-temperatured. And what happened is that people's temperatures spiked very quickly. The number of mortalities that occurred that day was over 700 reported officially. Some were lost and not sure if they were counted as mortality or not. The injured were more than 2,000, and it wasn't really a stampede. If not more than 90% of all the cases were heat strokes. Almost all of them. And it was a peculiar kind of heat stroke. It doesn't really fit into exertional heat or into classical heat strokes. They just raised their temperature really quickly. They started vomiting. They came in with explosive vomiting and diarrhea. A lot of them looked dead, and as soon as you cooled them down, they got up and walked away because their temperatures soared really quickly, but they came down also really equally quickly. And it was a devastating day for I was a program director back then, and most of the people that were seeing these people, or most of the physicians that were seeing them, were our residents. And the stories that came back were heartbreaking. They started doing all sort of innovative measures to try and cool down these patients. They would close down a room, put one fan for 10 patients altogether, because that's as much as resources that they can gather. They created a hall room for heat exertional illnesses, so they can get fluids and stay out of the heat until they recover. And what they described was something that you don't really see in most books. So I hope that was a good enough introduction of how important knowing and learning about heat illnesses and managing them is. With that, the Ministry of Health came up with these guidelines. They were published in 2019, 2020, and during that period, they established what we expect from every center to have in order to deal with heat illnesses. It was disseminated across all the hospitals in Mina and Arafat. The preparation list that was inside the guidelines was extensive. It included monitoring. The cooling method that they decided to use was mist with fan cooling, evaporative methods, which was almost the gold standard treatment at that time, as suggested by the Wilderness Medicine Society, which was probably the only society that was officially making guidelines regarding this. And they came up with pre-hospital protocols, which were somewhat simple, but it didn't really include a lot of cooling. And they had in-hospital protocols, which focused on most of the management. And during this period, you can see they had specific units set up just for cooling. These are the fans. Every bed has a fan, and the fan blows the mist itself. I don't know where they got these from or if they were made locally, but they were pretty effective in showering and cooling the patient. You can see my resident over there on the side during Hajj. When these things blows, this is what the curtains look like. I couldn't get a picture of the patient themselves for confidentiality. And they kept a registry that showed all of the incidences and cases that they had reported and the complications that they were expecting from these cases. But today, we don't only talk about how we should manage these patients, we also needed mitigation strategies to deal with heat-related illness. And the Mass Gathering Center here in Saudi Arabia, they got together, they decided that they need to look at all the evidence and come up with appropriate mitigation strategies, and this is what they did. They came up with a matrix for the heat-related illness, and they came up with all the suggested and published interventions
based on head-on metrics that can address this. They're telling me I don't have a lot of time, so I'm going to go ahead and move with the most recent guidelines. Last year, New England Journal of Medicine, they published the heat-related illness article, where they came up with newer guidelines. And I have to be clear about one thing, is that they had a focus on two new things. One of them was that they focused on cold water immersion as a cooling method, the preferred cooling method. And the second thing is that they wanted a target temperature of 0.2 to 0.3 degrees centigrade per minute cooling. So you need an evaporative method, usually doesn't reach that level. If it reaches 0.1, that's an extremely effective method, or the patient's probably not a heat stroke. They also came up with mitigation strategies of their own, but they looked at general population, athletes, and outdoor workers. I also think that mass gatherings may have a specific kind of population that probably doesn't meet any of these three. So, in order for me to close, since it looks like this topic is going to be covered extensively afterwards, one of the things that I think that needs to be looked at, since cold water immersion is going to be the preferred method, we still need a lot of research telling us which is the optimum temperature, the best methods to incorporate it into your practice. Do I have to do immersion, or is there some other method to get the water onto the patient to cool them down quickly, which is more effective and which is the safer method for our special population like elderly? Those are questions that still need to be answered about when we're talking about cold water immersion. There are some new medications that are coming up. Dantrolene seems to have reached the dead end, but allopurinol seems to be showing some promising results. We'll wait for some final official paper on that. Activated protein C seems to be another topic. When we talk about mitigation strategies, we also need implementation studies telling us whether these are effective or not. And we need some innovation to make this an easier process, because those who have worked in cooling units, it's the most wet and most difficult place to work in. And thank you all for your time.
Thank you, Prof. Majid. Our next speaker, it's my pleasure to introduce Dr. Cecilia Sorensen, who is the director of the Global Consortium on the Climate and Health Education at Columbia University, assistant professor of the Emergency Medicine at Columbia Irving Medical Center, and associate professor of the Environmental Health Science at Mailman School of Public Health, Columbia University. As a physician investigator at the nexus of the climate change and human health, translating research into policy and clinical action, and education to build resilience in vulnerable community in the focus of her research. Her recent work has spanned domestic as well as international emergent health issues related to climate change, including extreme heat, degraded air quality, extreme weather event, emerging infectious disease, women health, and worker health. Dr. Sorensen is a member of the Lancet Countdown on the Health and Climate Change and serves on the National Academy of Medicine Action Collaboration for Decarbonization of the U.S. Health Sector. She is the co-editor of the textbook Climate Change and Human Health from the Science to Practice. Please join me welcoming Dr. Cecilia.
Hello, everyone. Good morning. It's wonderful to be with you here today. I've been asked to speak about health as a lever for climate action. And as an emergency medicine physician, I come to this space thinking about how do we build capacity? How do we build momentum, awareness among health professionals, including doctors, nurses, public health professionals, because I think they are the lever for climate action as it relates to health. So I want to start by sharing a video. Can we get the video? This is a video which my center, the Global Consortium on Climate and Health Education, just produced with the BBC. You are all getting a sneak preview because it's actually not going to be going live until tomorrow, but it's tomorrow somewhere. So if we can start the video over with sound, that'd be great. All of life flourishes. I feel like this planet is a gift, and we're surrounded by so much beauty, and we have this position where we can destroy it or we can take care of it. And it turns out when we take care of it, all of life flourishes. When I was growing up, the poster child for climate change was the polar bear on the iceberg. That was what we thought of. We thought about animals that were far away and things that were changing, glaciers that were melting. But more and more, the exposures that we're seeing resulting from climate change are things that we've been seeing a ton of almost every day. Exposure to severe extreme heat, more wildfires. We cannot just stop breathing the air or stop drinking the water, right? But we know certain people are more vulnerable, like the very young, the very old, people who have any chronic underlying medical condition. I see these impacts of climate change on health nearly every day that I work in an emergency room. Our healthcare systems are dealing with climate change, I would say, on all fronts. There's been really good research which has shown anytime temperatures get above a certain average that we start seeing increases in morbidity as well as mortality. My name is Cecilia Sorensen. I'm an emergency medicine physician, and I'm a climate doctor. Climate doctor is a new breed of medical professional who focuses their work on understanding the complex links between climate change and the health of the patients that they take care of and the communities that they look after.
My wife is, she's a force of nature in a good way. She's a talented and intelligent leader in her field. She's a great partner in life. She's my adventure buddy. And that spirit of adventure is very much reflected in her professional endeavors.
I'm an associate professor of environmental health sciences at the Mailman School of Public Health at Columbia University in New York City. I also direct the Global Consortium on Climate and Health Education, basically over 300 health professional training schools in over 60 countries, where at the level of the dean or head of school, they've pledged to train their students in climate and health. Thank you all so much for being here today. We look at North America and we're seeing, the darker the circle is, the more evidence or certainty we have that these impacts are happening and they're truly. Bringing health into the climate conversation is relatively new. Doctors aren't trained, and nurses aren't trained to think about environmental health. I think the result is that we're not necessarily diagnosing climate and health related issues as well as we could. And when we're not identifying that our patient's health is being impacted by this, we're not necessarily providing the right treatment.
Interactive workshops are really critical to training this generation of providers to effectively provide care in our changing climate. We're able to draw connections in real time and see climate change and health in practice in these types of workshops.
I think of workshops like these as being most important for the patient at the end of the day. They are going to make healthcare professionals, the nurses and the social workers treat patients better and understand their context better. And that's going to allow me to be a better caregiver to patients at the end of the day.
We're here in the Columbia Medical School SIM Center. SIM centers are used around the country and around the world to train medical students, nurses, physicians even, in understanding cases that they are likely going to be seeing in their medical practice. It's been really, really hot outside. We've been seeing a lot of cases of heat stroke. Do you guys think this could be heat stroke?
Yeah, it's a good idea. It's something that we had thought about.
Between the years 2000 and 2016, over 125 million people were exposed to heat waves. Heat-related illness is a spectrum of illness. On the severe end of the spectrum is what we call heat stroke. And we diagnose it based on an elevated body temperature and neurologic dysfunction. Some of the work that we've been doing is to recognize that this is a very time-sensitive condition and to develop protocols so that when someone comes in and is diagnosed with heat stroke, a cascade of things start happening to immediately begin to cool people. It's one way that health systems can become more resilient and become adapted to these types of changing climatic conditions that we're seeing. I think the biggest challenges we're facing are around transforming the health sector to be more in line with the climate realities that we're dealing with. We're seeing more drought and we're seeing repeated exposure to wildfire smoke. Wildfires are a natural phenomenon. They've always happened and they will continue to happen, but they're getting worse because of climate change. And as we experienced recently in New York City, there were wildfires in Canada and we had the worst air quality day in the world.
By early afternoon, the sky was really, really dark orange. It stung my eyes. It made me cough a lot. The air quality was just horrible.
The health impacts from breathing in wildfire smoke can be as much as 10 times worse than breathing in simple tailpipe exhaust. How do we equip health systems to be able to deal with this? It's very difficult, but it's something that we can and need to address. Climate change and our health are intrinsically linked because climate change affects the air we breathe, the water we drink, the soil we grow our food in. We are only as healthy as our planet is. We as health professionals, we are really the first and last line of defense for our patients, for our communities, when it comes to the health impacts of climate change. Thank you. All right, so thank you so much for your attention for that. So I'm going to just speak a little bit briefly about health as a crisis in the setting of climate change. So the IPCC recently released a report where they called climate change a code red for humanity. We know the impacts of climate change on health are rapid, they're spreading, they're intensifying. We know that of 11 categories of diseases and illnesses that together comprise 70% of global mortality, that all of these are climate sensitive. And climate sensitive means that they're changing their distribution, their prevalence, and their frequency as a result of climate-related factors, such as changes in air temperature, air pollution, the changes in where vectors are found. For example, we see malaria, dengue, diarrheal diseases, salmonella, respiratory tract infections, non-communicable diseases, cardiovascular diseases are all changing because of climate-related factors. Here we're looking at impacts across human systems and infrastructure related to climate change and health. We see impacts on water scarcity and food production, impacts on health and well-being, and of course impacts on our cities, settlements, and infrastructure. And these impacts are being seen across the globe. The key here is that the darker the circle is, the more evidence or certainty we have that these impacts are happening and that they are attributable to climate change. Notice that where we have blank circles, that's not necessarily because there aren't impacts there, it's because we don't have any research to understand what these impacts are. Another key finding of this IPCC report is that climate change is worsening health inequities. We know that everyone's health is vulnerable, but that climate change preferentially is impacting those who are marginalized or socioeconomically disadvantaged. New research from the World Bank Group shows that up to 132 million new people will be pushed into extreme poverty by climate change by the year 2030, and much of this is due to the impacts on health and on livelihoods. I think this is our silver lining here, though, and I think that's what I'd like to really focus on today. We know that the severity of climate-related health risks is highly dependent on how well health systems can protect people. So said another way, these health impacts are not inevitable, but that we need to work very, very quickly to prepare our health systems to be able to protect the health of vulnerable patients. And it's good news. So we as health professionals, when surveyed globally, 95% of doctors and nurses already understand that climate change is impacting the health of the communities and the patients who they take care of. Yet they identify again and again that education is a key barrier for them in understanding what they can do about it. And so there was a survey which was done by the World Health Organization, and they found, again, that 54% of countries flagged insufficient human resource capacity as a main barrier to the implementation of national climate and health plans. So although we know these impacts are happening, we don't have the training, we don't have the expertise, and we don't have the capacity to do these urgent actions that we need to do in order to make our health systems more resilient. And so because of that, the Global Consortium on Climate and Health Education was formed in 2017. It was born out of a meeting at the Paris Climate Accords, where deans of schools who train health professionals got together and said, we're going to form this consortium to ensure that 100% of health professionals globally have the knowledge and skills to recognize, respond to, and prevent climate-related health impacts. So what's our approach? Well, we obtain commitments from health professional schools to educate their students on the health impacts of climate change. We bring together institutions to create and share best scientific and educational practices. We develop global standards and resources, and we work to build a pipeline of health professionals who focus their work in this area. So right now we have 335 academic institutions from 60 different countries, and we invite any health professional training institution to join us in this important mission. We also work with over 100 governmental and non-governmental organizations globally in order to provide capacity building work. So what is it that we need health professionals to do? Well, if you look at health professionals, we are many things. We are private citizens. We're institutional leaders. We're trusted community voices. Many of us are researchers, and we're clinicians. And in all these different roles, we have an ability to use our trusted voices to protect the health of the communities where we live, work, and serve. This responsibility does not fall on one specific health profession. We need an interprofessional, interdisciplinary approach to this, which includes health systems planners, clinical professionals, healthcare system leaders. We need social workers, behavioral scientists. We need our meteorologic community and our environmental health community to come together to devise innovative solutions that will really work in specific geographies, because we know that every different place is experiencing climate change differently. So what we do at the consortium is we really have a multi-pronged approach in order to build capacity. So first off, we support institutions and faculty who train students. One of the things we learned very early on is that this generation of students wants climate in their education, but the faculty never got this training, so they don't know what to teach. So we work with faculty to build their capacity. We also support existing health professionals through continued education opportunities. We provide technical support and partnership to health professional societies and associations. We work to promote transdisciplinary climate and health research. We partner with governmental and intergovernmental organizations to provide technical support and consultation, and we support students through student-led initiatives. So here's just a few examples of some of the work that we do. We've partnered with many different institutions to run broad trainings. For example, these were a series of trainings that we ran this past spring. And what you'll see here is what we did was we took a very regional approach, because we know that the health impacts of climate change are different in each region, and each region needs specific interventions to protect health. So these courses took place in North America, in the Caribbean, and in South America, and you can see our partners here. And just over the course of 2 months, we trained over 5,000 health professionals, which was incredible. We also have a learning collaborative among our members where they come together to network, to collaborate, to share ideas. This was an initiative we ran with the Ministry of Health of the Bahamas to train health professionals alongside community leaders to build resilience against severe weather events such as hurricanes. We worked with the Andean Health Organization recently to train ministries of health of 6 Andean countries so they can build health sector resilience within their region and also within their country. And we partner with UNICEF in order to build technical guidelines to protect the health of women and children under various different climate-related exposures, such as extreme heat. So that's a little bit about our work. All our resources are available free online. That's the website there. I've been told I have 2 minutes left, so I'll step aside for now, and thank you so much for your attention.
It's my pleasure to invite our next speaker, Dr. Rivati Falki. She's the Global Director of Health and Nutrition at Save Children International. She's an accomplished global health practitioner with over 15 years experience in working global health in a different part of the world. She's also have honorary associate professorship from Global Health at Heidelberg Institute for Global Health, HIGH, from Germany, and the University of Nottingham, UK. She was the head of climate change at the Health of UK and Health Security Agency, and also she served at the UK government national focal points and a co-chair of the Health Climate Working Group at the WHO Europe office. Dr. Rivati was the founding chair of the first Health System Global Thematic Working Group on Climate Resilient and Sustainable Health System. As a global director, Dr. Rivati is accountable for the quality and impact on our health, nutrition, and WASH programs across development and humanitarian context globally over more than 66 countries. Dr. Rivati will speak about the health, climate and health system resilience. Please welcome Dr. Rivati.
Yeah, morning everybody, and it's a pleasure to be here, and lovely to see some of the familiar faces in the audience. So I'm going to talk to you about climate resilience and sustainability of health systems, and the first two slides are just a reminder for us as health practitioners, but also as decision makers on where we are with our current commitments for the targets for global temperatures. And it's an important discussion as we head within 4 weeks to COP28. So even accounting for all the commitments adhered to, we are still on track of achieving more than 2.7 degree Celsius warming of global average temperatures. And not to say that this particular region is of higher vulnerability, because the temperature rise will be almost 20% higher than the global averages that have been recorded. 60% of the population in the region also has very little, if any, access to potable water. So water security is probably one of the biggest priorities for the region. And it's also an economic argument, because almost 70% of the GDP in the region is vulnerable to water stress. Now, even in the most optimistic scenarios, we will most likely exceed the 2-degree world that we have envisioned ourselves in the Paris Agreement, with the ambition, of course, to keep it below 1.5 degrees. And what you see here is, of course, a strong plea to all of us that we should not let the ambition for 1.5 slip away. And of course, I think the evidence is very likely indicating that we will exceed the 1.5 degree ambition that we have. 2023 was probably the year that strongly indicated this trend. About a third of the days in 2023, the average global temperatures was at least 1.5 degree higher than the pre-industrial areas. And this is, I think, a very alarming news for all of us. There's also 66% likelihood of exceeding the 1.5 degree threshold at least 1 year between 2023 and 2027. So we have, unfortunately, put ourselves on track for missing out the opportunity. And there's enough evidence of the huge difference a 0.5 degree world can make to health and health systems globally. So I would like to iterate that this is probably one of the biggest priorities for health systems, to contribute in their own way through managing the health impacts, but also through keeping its own carbon footprint under control and maintaining the ambition for a 1.5 world. I won't go into the details of what does this mean for health, because my colleagues previously have highlighted them quite well. But I'd like to say that the attribution of climate-related diseases and mortality is probably the biggest challenge that we have had. And yet, a recent study in 43 countries does report that 37% of the heat-related mortality was attributed to climate change. So of course there is methodological advances that are allowing us to improve our capabilities of attribution of health impacts to climate change. And of course, another study that I would like to quote here, specifically from the region, conducted in 19 countries in the MENA, were also that under high emission scenarios, the annual heat-related deaths will rise approximately from the current 2 per 100,000 deaths to 123 per 100,000 deaths by the period between 2081 and 2100. And although the numbers in the region are currently lower than the ones in Western Europe and Australasia, however, the percentage increase by the end of the century will be higher for the region. And not to say that the studies do indicate that the establishment of over 50 degrees of surface temperatures in the region with high likelihood, and that would basically test the limits, the physiological limits of adaptation that we can have as humans. And the same study also highlighted the limits of air conditioning, which is a widely used adaptation technology in the region, and even that was not a factor enough for the associated heat-related mortality that was recorded. Now, the direct and the indirect health impacts have probably been outlined well, but the health system's impacts are probably also as important, particularly for service delivery interruption. And most of our work at Save the Children is in low and middle income countries, but not to say that we have witnessed enough service delivery interruptions in the last 2 years with the pandemic that every country witnessed. Apart from the infectious disease transmission, there is also a huge infrastructure conversation that we need to have from a health systems perspective. Not to say that there are populations which are disproportionately affected, and with my NGO's focus being targeted on children. Children born today are twice more likely to experience wildfires, 2.8 times more likely to experience crop failures and floods, and also droughts, and about 6.8% more likelihood of witnessing heat waves. Now, this is a huge burden given that we have almost 2.2 billion young people and children in the world. So it's a huge burden, and already currently 1 in 4 children are exposed to heat wave frequency, and this will rise to all the 2 billion children that we will have, additional children that we will have in the coming years. Displacement is a huge conversation also to be kept sight on, particularly from the resilience of health systems. So what are the challenges that health systems face? I think the first one is, of course, that even currently, less than half of the world has access to essential health services. With that level of operation, the healthcare's climate footprint currently is equivalent to 4 to 5% of greenhouse gas emissions worldwide. So imagine the challenge that these systems are based is to scale their functions up, but at the same time keep their emissions down. And this definitely requires improving the sustainability, the environmental sustainability of the health systems that are at the front line of delivering services to these populations. Not to say that almost 25% of the global health care facilities do not have adequate wash facilities, and that 1 million deaths each year are associated with unclean births. Almost 60% of the healthcare facilities in sub-Saharan Africa do not have access to electricity, and that also translates into direct mortality of both neonates and mothers. So that said, the environmental sustainability of healthcare systems is an issue of health because it does translate directly into not just deaths, but also the number of people who do not get adequate care when they need it, where they need it, and at the level that they need it. The good news is almost 70% of the initial NDCs that were submitted in 2019 did include health, but that was predominantly from an adaptation perspective. So the WHO launched a set of guidelines for climate resilient health systems and the sustainability of health systems as well. And what you see on the screen are the 10 action points that the WHO has suggested countries to endorse. And we at Save the Children are predominantly engaged with 5 of them. The first one, of course, is health interventions, health workforce interventions, not just from capacity strengthening, but also how do you say that? Like empowering them to advocate for stronger action within health systems and communities for managing the health impacts of climate change. Energy interventions, of course, as we have just seen in the previous slide, wash services that are offered, and not just from routine health service delivery, but also in emergency settings. And then the infrastructure, technology, and products interventions, where we do talk about assessing the vulnerability not just of populations, but also of the health services and the health systems themselves in how services can be updated. And finance, of course. So finance is a huge conversation to be had. And the attached program of the WHO does ask countries to sign up for resilience and sustainability health system. What you see on the screen there are the 21 countries in the MENA region, 13 of whom have signed up for climate resilient health systems. 10 of them have signed up for the sustainability, and about 5 for the net zero commitments. And below you see the global averages, where 76 countries have currently signed up for the attached program. So obviously this is something that can be considered at the regional level. And of course, the sustainability finance conversation is quite big, also in the upcoming COP28 conversations. And I think from the regional perspective here, conducting awareness campaigns of the importance of adaptation within health systems is an important one, showcasing success stories. So some of the countries are at quite forefront of how these things are achieved within health systems, so how knowledge sharing can be facilitated in the region, and of course the delivering of training capacity and capability in the region is also quite interesting. Coming to the work that Save the Children is working with, so our focus is on community health systems and of course strengthening of primary healthcare systems for the achievement of UHC PHC. We deliver climate related health programs in almost 46 countries of the 120 countries in which we have presence through country offices. We do systems-based mapping, where we can, together with the communities, prioritize what the health systems priorities for the countries are. And at least 10 of our country offices are implementing renewable energy in health. The numbers are quite small compared to the footprint that we have globally, but we have set ambition for working with partners, working with the national governments, working with academic institutions and researchers to scale up some of the work that we are doing. And in Somalia, for example, we're working with Sustainable Energy for All and the Ministry of Health to scale up the electrification of health. And as I mentioned before, translating that into tangible health benefits at the population level. I'll end with 2 slides. The first one is, of course, I'm pleased to say that Save the Children is an accredited agency for the Green Climate Fund. It is one of the few health NGOs which is accredited for the Green Climate Fund, and we have about 8 projects in pipeline that we are developing with focus on community resilience and health. We have 3 under implementation, Vanuatu, Solomon Islands, which are focusing on community systems. But I'm very pleased to say that just last week we signed the agreement for the Laos project, which is the first ever exclusively health-focused GCF grant that has been ever allocated. So we are very proud that we are at the forefront of these discussions for raising finance for how health systems can be strengthened for responding to the climate emergency. I'll end with saying that we have 3 other projects that are being developed in Malawi, Senegal, and Indonesia, and all of our projects focus on strengthening not just the infrastructural capability of health systems, but also how that capability translates into tangible health benefits and measurable health benefits. So we're working with ministries, WHO, academic institutions in these countries. And MENA region is one region, actually the EMRO region of the WHO, where we have ambition of raising our partnerships and also working together with the academic institutions here to explore some of the work that you are doing and join forces together with you to scale up action on climate change and health. So this is also an invitation to everybody. Please reach out to us if you would like to collaborate with Save the Children International. Thank you very much.
Thank you, Dr. Rivati. So our next topic will be on the impact of climate change on health security. It will be presented by Professor David Calloway. He's a professor of emergency medicine at Atrium Health in Charlotte, North Carolina, where he is the enterprise chief crisis operation and sustainability for the 3 largest non-profit health system in the United States. He also served as the chief medical officer for Team Rubicon, a global humanitarian response organization. Dr. Calloway is a recognized expert in the health security nexus with a career defined by crisis innovation. He worked around the globe, including South Sudan, after their independence to help build a nascent trauma response system, and in the Hashemite Kingdom of Jordan as a fellow investigator of health security and impact of the Syrian civil war on the national health system. Dr. Calloway earned his medical degree from Georgetown and did his residency in Harvard-affiliated emergency medicine residency program, where he was the chief resident. He also holds a master's degree in public administration, focused on national security and crisis response. Please welcome Dr. David.
Thank you to Dr. Khan for the invitation and to the conference for putting on this great conference and tackling a very complex topic. Let's see if we can get going there. So we're going to talk about climate change and global health security. And briefly, here's the agenda. I'll probably stray off of it. But I think it's worth a discussion of what is health security, some of the factors that impact it, and how climate change then impacts those factors. So the WHO for over a decade has said that climate change is the biggest global health threat of the 21st century. The biggest global health threat of the 21st century. And Dr. Sorensen talked about 70% of the global burden of disease right now is related to climate change. 18% of global burden of disease is specifically related to air pollution from automotive vehicles. The WHO estimates by 2030, there'll be 250 million additional deaths between 2030 and 2050 due to climate change. 250 million additional deaths just from climate change. And so if this is a threat, obviously security should be in the same sentence. And so how does the WHO approach this? And let's just take a step back, and we're going to do a 1-minute history lesson here. So in the 1940s, the Constitution of the WHO, a long document, but there are 2 lines here that are of particular relevance to us. So aspirationally, health is a state of complete physical, mental, and social well-being, not merely the absence of disease. And the health of all people is fundamental to the attainment of peace and security, and dependent upon the full cooperation of individuals and states. So this is a framing from about 80 years ago. In the 1960s, the international health regulations were put into law, or internationally, and 70 countries came together and they said, look, what is the one transnational threat that our individual systems can't address? And it was infectious disease. And it was designed to combat the spread of cholera, yellow fever, plague, and smallpox. And this became the framework for global health security, because these were things thought to inspire pandemics and epidemics that no one country could prevent by themselves. And this led to this definition, this very narrow definition of global health security: the existence of a strong and resilient public health system that can prevent, detect, and respond to infectious disease threats wherever they occur in the world. Now, this led to the Global Health Security Agenda. You can see, prevent, detect, and respond. 70 countries signed on to this. This led to the Global Health Security Index, recently published in 2021, that looked at 195 countries' ability to protect, prevent, detect, and respond to infectious diseases. And spoiler alert, it's a great framework, but of all 195 surveyed, no one's ready to respond, especially post-COVID. The structure is great. You know, it's different categories, they do assessments. It's very local, they do local and regional assessments. But one of the things that is notably missing from this document is zero mention of the word climate change. Now, when they look at your preparedness and your resilience and response, certainly there's an environmental category that talks about, you know, allows you to comment on flooding or heat, but it's not explicitly demanded that that is a part of global health security. And right now, in the modern era, that is a deficiency. So some scientists have begun to call this period the Anthropocene, because this is the first time in history where humankind is responsible for planetary change. The changes we're seeing in our environment, biodiversity, animals, the environment in general, are largely driven by humans for the first time in history. Whether it's microplastics in animals, or in this case, macroplastics in this bird, whether it's air pollution, whether it's greenhouse gases that are driving climate change, this is human-driven impact on planetary health, and therefore it is also impacting our global health security. So I'd offer, and this is not my definition, this is an amalgamation from the literature, but a more universal global health security definition that says what we need are activities that are required to minimize the impact from acute public health threats, of which infectious diseases are a major component, threats that endanger people's health across geographic and international borders. So security from, but also security to maximize people's ability to lead healthy lives. Because we know, especially post-COVID, when we started to see all the different impacts on our health systems, that it's not just infectious diseases that create global health security risks. So if we go with this new definition, here are a few components that I think are necessary. We need to ensure access to safe and effective health services, technology, and products. We need the presence of resilient health systems, like was just discussed, that protect human life and good health during an emergency and after emergency, but also every day. Every day they need to see the benefits. Our disadvantaged and socially vulnerable populations need to see these advantages in a resilient system. And then we need to maintain social and economic stability. And now that seems obvious, but it's absent many health security discussions. So while we go through this, I want you just to pause for a moment and think about the Arab Spring and the Syrian war. Seems like a random thing to think about, but we're going to come back to this in a moment. All right? So when we look at the factors that are required for global health security, and we start to think about climate change, how does this impact global health security? And we heard from the prior speakers, this is about vulnerability, right? And so we look at climate drivers. This would be extreme heat, precipitation, weather changes, the exposure pathways, so heat-related illness. Are people vulnerable? Are they working outside? Polluted water? Do they have access to clean water? Do they have access to healthy food? Are we seeing increase in cardiac deaths because of heat? The health impacts. What is the impact on individuals and on communities? So again, heat-related illnesses, increased respiratory disease, kidney disease, infectious disease, chronic malnutrition in children, and then the outcomes. And if you look at the left, this should be familiar to disaster and emergency medicine physicians: exposure, sensitivity, and adaptive capability. So global health security in the modern era needs to work to reduce exposures, to decrease sensitivity, and then to strengthen adaptive capacity in communities related to climate change. So I'm going to briefly wave top, just very broadly, not deeply, go into a few direct impacts of climate on global health security and a few indirects, and then we'll wrap it up with returning back to Syria. So extreme heat, we've seen this, we know this, everyone knows this here. We are living in the hottest period in recorded history. This last summer, we had 90 days of the hottest sustained temperature in recorded history. Almost 4 billion people were exposed to extreme heat. Over 1.5 billion were exposed to it every day for a 90-day period. That is a lot of people. In the Netherlands, there was a 5% increase in mortality related to climate change and heat. In the United States, we saw dramatic increases in emergency department visits for heat-related illnesses. This put a tremendous strain on a system that was already struggling as it recovered from COVID. Who's at risk? Well, in addition to the 3.8 billion, 1 billion workers work in areas where they are exposed to extreme heat. The children and elderly we talked about already, extremely sensitive and vulnerable, and then people in low socioeconomic status. The urban poor and then low and middle income countries. People who can't afford to mitigate with air conditioning or inside jobs. What's the global health security impact? Heat is the #1 climate-related direct cause of death, about 500,000 in 2019. 54% increase in mortality in the elderly over the last decade. We see physical and mental health implications from heat illness. And then if we go to indirect, we see economic losses, increased emergency service utilization, stress on the system. And again, when we talk about security, stress on the system breeds insecurity. And so these are important factors to consider. Extreme weather, the second direct component. And you'll note that a lot of these are direct and indirect, but we'll talk about the direct impacts of extreme weather. So this photo should be familiar. About 2 months ago, Cyclone Daniel hit the Mediterranean, record rainfalls in Greece, Turkey, and Bulgaria, and then an unexpected landfall in Libya. And the cyclone had impacts of direct death from drowning and trauma, but then it also overwhelmed the reservoir system, the dams flooded, 5,000 people died and 20,000 were displaced. So in addition to the drowning deaths and the trauma deaths, population displacement, increases in infectious disease, all complicated by the security situation present in Libya prior to this. In the US last year, 18 separate climate disasters that cost over $1 billion in economic damages, a total of $165 billion in economic damages from natural disasters related to climate last year. So who's at risk globally? There is no country or region that is free of risk from extreme weather, but the risk is different. In Asia, it's more flooding. In the Middle East, North Africa, Africa in general, drought is a big problem. And here's, again, some of the global health impact. So these are system impacts. Directly, 2 million deaths in the last 50 years, directly related to the extreme weather event, not the follow-on consequences of cholera outbreaks or displacement, but directly 2 million deaths. Over $4 trillion in economic impact. These are dollars that in theory could have been spent to build resilient systems, but are now built on recovery from these disasters. And then obviously population migration, which we'll talk about a little bit, and health system disruption. Infectious disease. So now we go back to the narrowly defined global health security. That still remains a core component of modern global health security. Infectious disease and climate obviously has a very tight connection. So here are the components in the way that we see vector-borne diseases and their prevalence. So vector and host abundance, the local prevalence of the disease within the vector, and then human population behavior. And you can see on the left, how does climate change impact this? So warming temperature, more precipitation, they're expanding the replication season, they're expanding the geography in which vectors can grow and impact human behavior or human disease. Also, as populations migrate, human populations migrate, they have collision with new vectors and can have mutations and spillover. And here are just two examples, right? There are a dozen infectious disease examples, but here are two classics. So the Aedes aegypti mosquito and dengue, and then the Anopheles mosquito and malaria. So Aedes aegypti and dengue has seen a 30-fold increase in the last 50 years, with over 390 million at risk and exposed in over 100 countries as of last year. This is a massive increase in this disease with significant mortality, up to 13% if not treated. Malaria, the same situation. As temperatures increase, malaria mapping has shown that it's increased away from the equator at about 4 to 5 kilometers a year and started to impact populations at higher elevation. One study shows that in the next 20 years or so, we can see an increase from 45% of the population in the world being exposed up to 60%. So that's 5 billion people who will live in areas that are at risk for malaria as climate continues to change. The indirect impacts. So food security, for those of you in the room, we all know that food is critical to health, but oftentimes not considered in the global health security discussion. Global trends, again, you've seen this especially with the war in Ukraine and the increased wheat prices, but we've been seeing this for over a decade. Increased food insecurity, you can see the numbers. 2019 and 2022, a doubling in people who are considered food insecure. And then last year, 50 million people in famine, 80% of which are in Africa. This has implications just for pure humanity, but also when we think about our transition to a green economy, a majority of the resources required for this transition are in Africa. All of these things tie together when we talk about security. How is climate change impacting this? It's the standard litany of criminals. Flooding, drought, fires, ocean acidification. We're seeing decrease in productivity of crops globally. In the United States and Texas, 40% of the cornfields are deemed in poor or very poor quality. Across Europe, corn yields are down, and in India, wheat yields are down as well, secondary to drought and changing climate. How does that impact global health security, you ask? Well, that's what we're here for, right? We know food insecure children, you have increased mortality, you have kids that are not going to school, which has long-term impact on the economy. It keeps parents out of work as well. We have increased chronic disease burden as people have to spend more money on food, and in low and middle income countries, they spend an average of 40% of their income on food. That's money that can't be spent on chronic medications. And then destruction of wetlands and movement into areas that were previously forested or more wild, which increases our risk of exposure to new diseases and new vectors. And then migration. So in the last 10 years, all of the major migration events, most of the major migration events have been related to climate or conflict. And this graph shows 2016, the top 10 largest migration events were secondary to climate change all throughout Asia. This has very clear impact. It is loss of access to health resources. It's increased transmission of infectious diseases, both because people are moving and bringing diseases to new areas, but also because they're exposed to new vectors. And then it also puts strain on receiving health systems. And finally, conflict. So this is a map that we like to show with conflict and climate. These are two of the most complex interwoven crises we're dealing with in the modern era. So climate change results in a bunch of different things that lead to instability, that lead to national and international conflict. So resource competition, loss of income, food insecurity, and price shocks, all of these drive and fuel the ability to or the fuel conflict, especially in low and middle income countries. And so I'd like to bring it back to Syria for a moment. In 2006, the world experienced a drought in Russia and in Canada and Ukraine that decreased cereal and wheat production and skyrocketed prices. The Levant experienced in 2007 through 2010 the worst drought in recorded history. This resulted in Syria having 3 million pastoralists and farmers who were food and economically insecure, 1 million of which moved to Damascus and other urban areas. Coupled with the 1.5 million Iraqi refugees that had fled Iraq and gone to Damascus, there was a massive surge into the urban centers. And these urban centers didn't have the health infrastructure, didn't have the water infrastructure, or the food infrastructure to be able to take care of these individuals. Now, did climate change cause the Syrian war? No. There were other factors that were there. The tinderbox was set, but climate change may have caused a spark as it added additional stress onto the existing systems, and people said, we've had enough. So not only did it result or help to spur some of the conflict potentially, but what is the aftermath? 50 to 70% of the Syrian health system was destroyed during the war. What happened to the 5 million Syrians who left Syria? Some went through Turkey into Europe. 1 million went into Jordan. Jordan had agreed to provide all the resources to Syrian refugees that they provide to their citizens. That meant free access to health care. So now the Jordanian health system has 1 million more people to care for. That put strain on the system. People couldn't access care because Syrian refugees were accessing care. That created tension, right? It created resource issues and supply issues. And not only that, the Captagon epidemic. So this amphetamine epidemic that spurred from state-sponsored production of this amphetamine has now expanded into Jordan, the rest of the Middle East, Turkey, even as far as Asia. And this is certainly a threat to global health security. These are the consequences of how all of this is tied together, and climate change is a major factor. So almost done. What are the actions? I added this because I thought Dr. Hassani's comments during the introduction yesterday were phenomenal. No one is safe unless everyone is safe. That's the world we live in today, and climate change makes that abundantly apparent. So for those of us who do emergency medicine, we're used to this cycle, right? The disaster cycle, mitigation, preparedness, response, and recovery. What are some steps we can take? So from a mitigation standpoint, we need to accelerate transition to net zero economies. The health sector has a major role to play in this as a huge economic driver, but also one that has a moral mission to drive this. We need to acknowledge and promote climate as a health and security issue. We need to improve data sharing. There's been some great presentations today on how we can do that. And then from a preparedness and adaptation, we need to include climate in our hazard vulnerability assessments. We need to fund national climate action plans. Of all the countries surveyed, 195 countries that were surveyed, only 50% had a plan and only 9% of them had that plan funded. So we need to fund those plans. We need to look at strengthening health system infrastructure and supply chain. We need to work about, as Dr. Sorensen talked about, how do we train and educate our future leaders on this topic? And then we need to take pollution and waste as a healthcare quality, value, and safety issue. And that's what we can do in the hospitals. We can say this is about quality, value, and safety. So in conclusion, climate change and pollution, I think, clearly have an impact on human health and on global health security. We need to reframe our perspective on global health security to include the impact of climate change because it is truly a transnational threat. It is the ultimate risk amplifier for conflict and health insecurity, and it's also a peace inhibitor. And then we must act boldly if we're going to preserve humanity. Thank you again for the time. Appreciate it.
Thank you, Dr. David. Very enriching talk and sessions. We're enjoying it. Last but not least, Dr. Abdulrazak Boushama. He's a board certified critical care medicine from Javier Bichat Medical School, Paris. He practiced 8 years in Paris, then he came to Saudi Arabia in 1986, joined King Faisal Hospital and Research Center. Now he is the director and the chairman of the experimental medicine department at KMAR, King Abdullah Medical Research Center. Please welcome Dr. Abdulrazak.
Thank you very much. And I think it's very difficult to be the last speaker of the morning, just before lunch. Anyhow, in 1985, I moved from France to the Kingdom of Saudi Arabia to work as an intensivist. And during the summer of that year, more precisely in August, I was assigned to work in Mecca. I was told, you are an intensivist, and we need you to help in the management of acutely ill patients, particularly heat stroke. And I say, heat stroke? In France at that time, we do not study heat stroke because it was considered as an exotic disease in a remote place, in the tropic, in the desert climate like in Saudi Arabia. So I was assigned to that small hospital called Mina Al Jisr. And you see, Mina is a valley surrounded by this sand-baked mountain where millions of pilgrims gather. At that time, there were 800,000 pilgrims. So we were preparing for several days. And then in the morning, when the pilgrim moved from Arafat to Mina, by noon, the hospital was swamped. The hospital was jammed with cases of heat stroke. The emergency room, the recovery room, the ICU, the cooling bed unit, the floor, and the corridor, actually, and outside. So the patients were triaged like in a war zone. This is the first time as an intensivist, and I had 8 years behind me of intensive care, managing daily critically ill patients. Then I see so many critically ill patients in the same time. So the temperature was displayed is a digital display, and you could see 42, 43, 44. I never thought I would see that in my life, and patients were in shock, seizing, diarrhea, vomiting, and with this body cooling unit using evaporations, there was like a fog, so it looked an irreal image of heat stroke. Now, heat stroke is classically defined as rapidly rising temperature above 40 degrees and CNS alterations such as confusions, delirium, coma. And you can see in this cohort of 2,632 patients that we reported recently, the rectal temperature at presentation is very high, around 42. This is an average, so the range goes to up to 44 degrees. You can see the sign and symptom of CNS alterations, but the point here in these slides is very important is that, you know, in Mecca, you could see the hospital is in Mina, so it's very close to the patients. So the diagnosis of heat stroke is made maybe probably in half an hour, maximum 1 hour there in the hospital. So we see the patients very, very early. And you can see here in these slides that heat stroke is a systemic illness, is a multi-organ injury. Although we say it's heat and stroke, so everybody believes that heat stroke is just a CNS alterations and hyperthermia. But this is a multi-organ injury, and you can see here, acute kidney injury, some present with in shock state, respiratory failure, liver abnormalities, GI, etc. Now, 2 years later, this paper came out in the Annals of Saudi Medicine. These are epidemiological data of 5 consecutive pilgrimage. And I want you to focus only in August 1985, that month when I met for the first time heat stroke. And you can see the number of pilgrims, 852,000, and there were 2,134 heat stroke patients, of which 50% died in few days. Please note the incidence. You know, it goes from 22 per 100,000 population to 251 per 100,000 while moving from October to August. So the take-home message here that heat stroke is an epidemic illness. It always occurs in epidemic form. So you are facing many, many patients acutely ill. So the sickest patient you can see in ICU, and it directly associated with the weather, with the high temperature. So the intensity of the heat leads to more and more cases. Now, when I give some presentations in Europe or in the States, and I always show these slides of 2,000 cases of heat stroke and 50% died, and people look at you and say, oh, probably Saudi Arabia, they don't know exactly how to manage. This is why we have so many people that died. And in 2003, we have this extraordinary heat wave that hit Europe. In 70,000 people died in that month of August 2003, and of which France had 14,800 people that died from heat. These slides show you the people that died with heat stroke. These are confirmed heat stroke death. And you can see daily death of heat stroke. At the peak, there were 533 days in one day. So the equivalent of a big Airbus crash. And more important here, is 40%, let's say close to 50%, half of them, from whom to the morgue, it took less than 24 hours. So this is documented through the call, like the 911 in France. So the take-home message here is that heat stroke is a leading cause of death during heat wave. It's around total here in 10 days were 3,000 heat stroke out of the 14,800 heat-related death, followed by cardiovascular death around 20%. Is one of the most, if not the most, life-threatening condition to human, and is a true medical emergency. Now, the question that arises is how finally the heat kills us. And the second question, what happened to our body when we are exposed to extreme temperature? How we defend ourselves against the heat? And the third question, are we vulnerable? And if so, why are we so vulnerable to heat? Now, you know, we regulate our temperature to 37, and 37 degrees is not just a number. It's extremely important because our body, our cells, our molecule functions properly at this temperature. And the reason is simply because the protein, which are the driving machine of our body, we have the proteome contain more than 10,000 proteins. They do everything from growth, proliferations, immune response, inflammations, everything. They work in a narrow range of temperature, which means that when the temperature goes up, this protein do not function properly. Why? Because the function of the protein is related to their shape. And their shape is a three-dimensional configurations, so they can bind to a ligand and induce a signal or a functions. So when the temperature goes up, they lose these 3D configurations. They unfold, they misfold, they aggregate, they don't function. They become a waste, and they become very toxic. So we have to eliminate them. So not only we heat stops the function of our cells and our molecule, when it's higher, is extremely toxic. You can see here the cells, the normal cells in blue, and the cells heat, what you call the heat shocked. All the elements of the cells are destroyed. The cytoskeleton, the endoplasmic reticulum, where we synthesize secretory protein, the mitochondria that produce energy, lysosome, nuclei, where we have our genetic material. Now, after answering this question, how the heat kills, now, how we defend ourselves? Well, we have two major defense mechanisms. One is thermoregulations that try to maintain the temperature around 37. And if it's overwhelmed, we have another defense mechanism to try to prevent this protein to denaturate or the heat to destroy our macromolecule. These two systems are a prerequisite to live in this planet, not only for us, but for all the living species. Now, I have no time to detail the thermoregulation, but I will take just one key point, central point for the thermoregulation, which is the cardiovascular response to heat. And you can see this is a classic experiment, but is extremely important. So if you take a young volunteer and you make them wear a suit that you can perfuse with water. And the water, you can change the temperature, so you can induce heat stress at rest. So they lie in supine, so they are at rest. When you increase the temperature of the water, you can see here at before the heat stress, the skin temperature, TS, is at 32 degrees. This is our skin temperature that corresponds to 37 as a core temperature, central temperature. So when you induce heat stress at 40 degrees, you can see two things happen. So at rest, this is the cardiac output, and you can see that is around 6 liters per minute, and you can see the distribution of this cardiac output. So it goes to the heart and the brain, to the viscera, which means mainly the splanchnic organ, liver, gut, kidney, and stomach, a little bit to the muscles because you are at rest, and very little to the skin. So when you induce heat stress, you can see two important things happen. You double your cardiac output, it goes to 12 liters, and more important, 70% of this cardiac output now goes to the skin. Why? Simply because we need to thermoregulate. We need to keep this temperature at 37. So we transport the heat from the core, from the internal organ, to the skin before we dissipate them to the outside. 2 minutes? You promised 15 minutes. Okay, so anyhow, so that's, see, if the blood goes to the skin, so it's not anymore in the central circulations. And so in order to maintain the blood pressure, you have to close some beds, and we close the splanchnic circulations. The kidney and the gut and the pancreas do not receive any more blood flow. Now, the heat stress response, this is, what is this exactly? This is a transient program, so the cells shift its program from daily business, which is growth and proliferation, to stress. All the energy goes to the stress, the pathway goes to the, these are stress pathways that try to save again, to prevent the protein to misfold and to destroy all the organelle. So these are done by inducing the heat shock protein. The heat shock protein are proteins that are going to bind to this, to all misfolded protein, try to repair them, to restore the 3D configuration, and if it's not, they will take them to the garbage, which is the proteasome. So this is a recent paper just to show you what happened when we develop heat stroke, what's happened to the heat stress response, and what's happened to the temperature. So when the thermoregulation is overwhelmed, and you can see here, these are 20 patients, no? You can see, of course, the rectal temperature goes to 42.5. And we looked at the gene expression, the whole genome. And you can see under the circle, most of them are induced heat shock protein. So heat stroke occurs when both the defense system are overwhelmed. Now, why are we so vulnerable? And very quickly, thermoregulation, because thermoregulation is meant for very good heart, very strong heart. I think it's meant for hunter-gatherer, not for the modern human, which has with sedentary, grow older, and take medication for the heart. The heat stress response simply cannot be sustained because it's like in a war, the heat stress response. It's like in a war, you trigger the military, the hospitals, the firefighter, and you stop all other activities. So it cannot be sustained. So if the heat wave stays longer, so the heat stress response loses its potency. There is one solution to that, is the acclimatization, because it can enhance both the thermoregulation and the heat stress response. Now, I think when we face heat stroke is a race for survival. So, of course, early heat wave warning system is very important to prevent people to be exposed to extreme heat. But when there is heat wave or summertime, we should have a high index of suspicions, meaning that if we see someone who is collapsing and the temperature is 40, we should activate the EMS. We move the patient to a cooler place very quickly. We start external cooling. We check the airway breathing circulations, and we transfer to the hospital, keeping the cooling during transportation, and then treatment for organ support in ICU. This is now MENA with adaptive measures, with the tent, with the cooling system, modern transportations. You can see here the train. Thank you very much.
Thank you, Dr. Can you hear me? Can you hear me? Okay. Thank you, Dr. Abdulrazak, and all the speakers. We can take few questions. We're lucky to have the break, so we can take questions. Okay.
Hello, good afternoon, and thank you very much for the interesting talk about the climate change. I have a question to Dr. Rivati about using the artificial cloud seeding. As you know, nowadays many countries are going to this way by using the artificial cloud seeding and to induce rainfall. And so my question is, do you believe that using such a technique would increase the climate resilience and decrease the climate change? So thank you.
Thank you for that question. Unfortunately, I'm not a climate expert, so I will reserve my opinion about the technology or the approach for addressing climate change. But I think the important thing here is to explore all the different technology advancements that are available to us in addressing or reducing even the impacts of climate change on health. So apologies, I am not in a position to answer that question.
If anyone of the speaker has input to the question, please feel free. Dr. Hisham has a question.
Thank you very much for the respective panelists and the moderators. Very interesting session indeed. And I would like also to extend the appreciation for the organizers for the remarkable conference. Probably my question will touch base in several presentations today. However, I'll leave the choice for you to answer the question. So my question will be based on your experience during mass gatherings. So how can the healthcare facilities drive genuine actions and foster innovation in order to combat the climate change? And what are the measurable differences they may achieve in both, actually, the carbon emission and also providing sustainable healthcare practices? Thank you.
Well, I'll take the first sentence and hand it off. So I think the question was, what can healthcare systems do to improve sustainability and combat climate change? From an operational standpoint, the number one thing is to realize that green is the new black. And I heard this phrase last week. Most of the interventions right now that health systems can do to decrease their carbon footprint and decrease waste actually save money. So it's actually about being more efficient and respectful stewards of the resources that you have. So if you are doing nothing right now, the first year is going to be doing things that actually save you money and build what we call operational resilience, because you're taking money off of your operational expense and you can spend that other places. The next step is then investing your money wisely. And so we know that in general, if you invest in healthcare buildings that are more efficient, it costs anywhere from 2 to 10% more in your initial construction of a hospital to make it hyper efficient. And that usually pays itself off in anywhere from 3 to 10 years. It's probably longer in the Middle East where it depends regionally what your energy costs are, but it pays itself off within a decade. And so unless you're building a building that only lasts for a decade, you should be building it very efficiently, because you're going to be managing it for 20, 30, 40 years. So those would be two first steps, which is look at things like changing your anesthetic gas, reducing the number of trips that your fleet takes, making your buildings more efficient. And then obviously if you invest in technologies around renewable energy and microgrids, that also builds resilience, but also will end up saving health systems money that can be invested in other places in the future.
And I think I sort of see this in two parts. So I think what Dr. Calloway spoke of is changing the hardware of the system. And we also need to think about changing the software, which is what programs do you run and what are health professionals doing in the systems, right? Are they using resources like there's unlimited resources, or are they conserving resources, right? So behaviors of health professionals are really important, so they need to be educated. And then it's thinking about our protocols. So for example, during heat season, are all staff educated to recognize and diagnose and rapidly treat heat stress and heat stroke, right? And other types of issues like that. We also need to be thinking about how nurses and doctors can counsel patients, right? We know that there's many things that patients can do to prevent themselves from getting sick. And in the end of the day, that saves the system money, right? All those prevented emergency department visits and prevented hospitalizations are important as we try to reduce the total overall expenditure in healthcare and also the resources that are used by healthcare.
If I could just add one more piece to this. So going back to your question about mass gatherings and what can be done. So I'll just ask the question, especially with the Hajj, is it more cost effective to put in cooling stations, to give water, to put in tents in air-conditioned space for the 1 to 2 million people that come? Is that more cost effective than caring for a couple hundred patients in the ICU that have extreme resource requirements, of which 50% die? So overall, if you have one bucket of money and one bucket of value, which takes human life and financial value together, it is far more efficient to invest in the preventive strategies around mitigating the heat injury rather than treating it once patients get sick.
Yeah, and I would add just one thing that, when we define resilience, it's about the ability of the system to anticipate, to respond, to recover, and to learn. And I would stress a little bit more on the learn component of the health system, because as long as you're documenting the past experience of how the system reacted and recovered from the particular shock, I think that's an important thing too. So having that feedback loops into how the experience was in previous years, and then bringing those learnings into how the current approaches are designed would be good. And of course, we know that procurement systems are a huge component of the footprint of health systems. And just speaking from SAFE's perspective, we have procurement from almost 2,500 suppliers. And that is the first step that we have taken into looking at how we can improve or optimize and improve the efficiency of how procurement systems are improved for our own footprint. Thank you.
Hello, my question is for Dr. Calloway. You mentioned that migration would increase infection and would add to the problem. I don't know, I always thought maybe moving to a better climate would solve the problem rather than add to it.
Yeah, great question. So it depends why you move and how quickly you move. And so if you have resources and you say, well, the summers have been too hot in Riyadh for the last couple of years, so I'm going to move to Geneva. That's different than if you have a sudden onset emergency, a drought, a flood that causes mass rapid migration of people into adjacent geographies. Because the mass migration is what causes the problem. The individuals, one or two people moving, that actually probably is an adaptation strategy. But when you have large populations that move, it puts stress on the receiving system, first of all. It increases the likelihood that these individuals could carry new diseases into the new community. It increases the likelihood of exposure to new vectors. And then we all know just from disaster response, when you put thousands of people together in a closed space, you tend to see outbreaks of things like measles and cholera and other infectious diseases like that.
Thank you.
So my name is Mary Shostark. I'm a physician assistant and assistant professor at the Yale School of Medicine PA online program. I became somehow the token physician assistant to explain climate change and stuff to the International Federation of Medical Students, and they always invited me for conversations. And they did the study regarding that they only had, they found 15% of schools were teaching around the world about climate education. And they encouraged me to do the research study to look at PA and PA comparables around the world, because we exist in 80 different countries under 30 different titles. And we found that over 53% did not include education about climate. And so I do agree that it relates going back to education, because I see with my students when I teach, they don't recognize that air pollution is causing a respiratory problem. They don't realize that a hurricane is happening and is causing an increase in vector-borne diseases, and they're not putting those things together. And so I guess my question is to Cecilia is, I do a lot of interprofessional education work. That's what my poster is on in the hallway. Slight advertisement there. But it was mandated by the World Health Education to put that as an accreditation requirement to teach about interprofessional education into the education systems. And that has gone across the United States, but it's also gone across Germany and multiple other countries. And so my question is that push going to happen? Because I know so many educators feel like there's too much stuff in the curriculum all the time, and they also, in most of the studies, they feel like they don't have the ability to or knowledge to teach on this. So where is that push towards pushing the accreditors in multiple different countries and the WHO to put those guidelines forth so that educators can now start to develop that in their curriculum?
Yeah, that's a really great question, and I would say I think it's coming. I think we're getting close to the cusp of it. Right now it becomes sort of a voluntary situation, right? So in America, the American Academy of Medical Colleges recently did a study which showed that roughly 50% of medical schools in the United States are teaching about climate change. But what does that mean? what are people learning? I mean, because you mentioned the word climate change in one lecture, does that count as teaching about climate change, right? And so what we're working on at the consortium is developing those very specific competencies. So for example, to be able to recognize and treat heat-related illness, to be able to counsel pregnant women as to how they can stay safe from air pollution. Very, very specific. We have to be able to name exactly what it is that we need every different type of health professional to do. So we have to define these roles and responsibilities in order to come up with the competencies which then result in training, right? I think that, there's this perception that, well, there's not enough room in the curriculum. What we've been doing is really saying we can integrate this into what's already being taught. So for example, if you're teaching about cardiovascular health and the functioning of the heart, we need to understand how heat stress impacts the functioning of the heart, how air pollution impacts the functioning of the heart. And that can be, 4 to 5 additional slides in a lecture, right? So we're seeing that it's actually can be seamlessly integrated into a lot of the education that our health professionals are already getting.
I agree. I think there's pushback sometimes from some of the educators, but I use your competencies a lot, so thank you.
Cool. I agree with you. There's pushback.
Thank you for the interesting talk. I have a question for Dr. Rifati. What role do you see for civil society organization in addressing the climate change and impacted on the health system?
Yeah, I think that civil society organizations can play two or three key roles I would outline. The first one is, of course, that we are closest to the community. So, in terms of our ability to work consistently for long durations of time in a sustainable way in how climate change impacts can be documented at scale at the community level, but also how interventions can be implemented at scale from a community perspective. I think that's the first. So operationalizing or translating evidence into action, I think NGOs are very well placed in kind of, bringing that action. The second is, of course, speed. Because if you combine all the civil society organizations who are working with local partners, the speed and the scale that we can achieve together is probably quite high. The second thing I would say is also elevating the voices of the most vulnerable. So, of course, my organization speaks for the causes of children, but there are other organizations who will speak for the indigenous populations, who will speak for the elderly, who will speak for, other marginalized groups, hard-to-reach groups, and the neglected ones which don't make it into how impacts are assessed, neither into how interventions are targeted or delivered. So I think that is a very important role. And then the last is probably our convening role, that how NGOs can bring together different stakeholders and also have the accountability aspect. So yes, there are global commitments on how climate change will be addressed, or climate change and health will be addressed, but as civil society organizations, we are in a unique position to hold ourselves and the other stakeholders accountable for how we are responding to the climate crisis. Thank you.
Thank you very much, Dr. Rifati.
Thank you very much. We have to close because we want to use what left from the break to get ready for the next lectures in the day. So we invite the speakers and the panelists for a group picture.
Please join us for lunch at any of the restaurants in the hotel. Everyone is invited. Thank you. We will be back at 1 for the next session. Thank you very much.
third session for today, the event experience. Please welcome Dr. Luis Suleimani. He's an associated professor and emergency medicine consultant in emergency department at King Abdulaziz University. Also, he's the deputy director of academic affairs in the clinical skill and simulation center at King Abdulaziz University. He did his disaster medicine fellowship at Harvard University. He's the disaster medicine section head at the Saudi Society for Emergency Medicine. Our next moderator is Dr. Abdulaziz Al-Rabi'a. He's an associated professor and consultant of emergency medicine at King Saudi University. He has a master in disaster medicine, head of emergency medicine services, and director of EMS and disaster fellowship program. He completed his emergency medicine training, followed by a fellowship in trauma and emergency medical services at the Royal Hospital in Australia.
Assalamu alaikum. Hello, good afternoon, everyone. Welcome to this fifth mass gathering event. We are welcoming you all in this event. I hope you had a great lunch before this session. We'll start our first session with Mr. Gidi Julian. He's a pharmacist epidemiologist with more than 10 years experience of disaster health management as an WHO Indonesian Emergency National Officer. He's also a researcher and an instructor for hospital disaster planning and consultant for disaster health management at the Center of Health Policy Management at Gidi Mada University in Ugadita. Currently, he is an LPDP scholarship awardee for PhD program and appointed as one of the experts in the team of EMTs and MCIs for MOH in Indonesia. I would like to welcome you, Gidi, and if you can join us here, please.
Thank you, moderator. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. So maybe I'm the only speaker from the low middle income country here. So nice to meet you. I would like to present about football stampede in Kanjuran Stadium. It's a tragedy just 1 year ago from the perspective of disaster preparedness on mass casualty incident. So this is the report from the committee built by the government, and I want to acknowledge the Global Center for Mass Gathering Medicine for bringing me here and present the lesson learned from Indonesia to the world, that maybe in the low middle income country we should not have the same experience again in the future. So this is the background. So this is at first we thought that this is a business as usual, like a football match in the first division of our league. But eventually, after the incident happened, which involved the 45,000 spectators during that night, 45,000 spectators, we found out that this business as usual is not comply with any SOPs at all, like from the FIFA, from the AFC, from the local our football associations. It caused 712 victims and resulted 135 died. And we just found out that also together with this event, the SOP was violated, and the nearest district health office, nearest hospital, public hospital, doesn't have the disaster management plan, which is mandatory to have in our country. We have like 514 districts, 34 provinces, and around 20,000 hospitals, and they are mandatory to have this disaster management plan. And this is the situation in the stadium. And you see the slope in the stadium, in the tribune. It's like quite challenging for the kids and also for the elderly. So most of the victims are children, because it occurs during the weekend, and these 45,000 spectators not expecting any away supporters. So actually the SOP that violated by the organizing committee is that the police should forbid to have the tear gas to the stadium. Eventually, during that night, as the team is not get the good result, it's like a lose from the away team. So one of the supporters go to the field and then make chaos. The police overreacted to the situation and shot the gas tears, and the gas tears spread by the wind to the east part where the door or the gates are closed. And that's what then we found out that the steward, the one who responsible for the escape route, wasn't there, and the gate was closed for like 3 hours. Then the 700 people stuck in that gate for 3 hours. And the police or the law enforcement, the local authority, prioritize the athlete first to be evacuated. They close the street and they have no coordination with the medical officers. So there was no ambulance come and go to the stadium to rescue the spectators. They only prioritize the athlete. So this is need to be discussed in the future. So the methods in having this research is we have the conducting media observation by the experts from the emergency specialists, and also in-depth interview with the pre-hospital medical coordinator in the hospital, the nearby hospital, and also we conduct the desk review of the incident report compiled by the Malang districts, Kanjuruhan Stadium Incident Joint Independent Fact-Finding Team. So we try to extract the health part from this report. So the finding is that it's clearly not coordinated between the health authority and also the law enforcement, especially the police, the transportation office, and also the army. So the health workers cannot handle the victims in timely manner. So no triage conducted at that night. And the hospital, nearby hospital, also not prepared for emergency situation involving mass victims, especially when we discuss about the district health offices, Malang district and also Malang city. There are 2 districts affected. The regional disaster plan doesn't have this operational command system. We have this ICS, as yesterday mentioned. Actually, we have 2 systems. One system in the hospital. So hospital, they use MIMS, Major Medical Incident System, Management System, but the local government, they use ICS. So yesterday even actually a debate quite interesting for me, because how to manage these 2 systems all together. The ICS interoperable with MIMS in the hospital. What's quite funny, I don't get the chocolate yesterday. Anyway, yeah, maybe today, yeah. Yeah, so you can see in the low middle income country, we have this this is even, thank you very much, sir. This is even in the daytime. The ambulance stuck in the traffic. And this is what happened during that night. So we have to get this, since you're here, I think the memes is quite suitable for the event, no? But apparently, the one who managed this kind of situation using the ICS, which clearly didn't work at that time, any time. Yeah. So as the result, after a week after the incidents, the Minister of Health has get very angry, and also some of the Ministry of Coordination also. They asked the experts, one of the experts is me, to develop the guidelines. So it's clearly that we have the guidelines, but again, I said many SOP was violated, it's not working there. So we developed new guidelines for the mass gathering activities established for football matches. This is like real football, not American football. Yeah. So they said it's hooliganism, but again, this morning, Dr. Donald said that actually it's not hooliganism, it's the situation that produced the riots. So these guidelines are mandatory for these 514 districts in Indonesia, and all should comply for this guideline to plan the events of football. And a new task force formed in the Ministry of Health for the National Ambulance Command Center. So they can dispatch as many as ambulance to the site with the coordination with the police and the transportation office. So there is no traffic jam stuck during the incident. So the recommendation is we have the regional disaster plan. We call it disaster contingency plans, mandatory for 514 districts and 34 provinces, managed by the NDMA, the National Disaster Management Agency. And this regional plan should include the mass gathering as one of the hazard. And they should be aware that the risk of stampede and substance abuse in sport and cultural events, as the events could be recurrent. But now the stadium is demolished. As I said, that because it's an old stadium, but again, they built the new stadium, and we don't know the safety and security of the stadium. So in 11 September 2023, the same riots occur, but now the difference is now we have these guidelines. So there was a substance abuse. Although we tried to limit the spectators come to the stadium, but still our stadium capacity is like 50,000 in every province. So half of it is like 25,000. Here, only 15,000 because in the second league. But among these 15,000, still a substance abuse, and then there's an incident. Apparently, they can implement the guidelines very smooth and clean. They give the access for the ambulance, and the police very much cooperate. They don't have this, they don't bring this tear gas anymore, and they have the steward also accompany the ambulance. So, but again, the problem is how the health facilities operational with the regional disaster plan. That one, and the second one, the interoperability between the regional disaster plan with the health facilities disaster plan, which one using the ICS, one using the MIMS. So I think that's conclude my presentation. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Mr. Julian, for this interesting talk. Our next speaker is from Korea. He's Prof. Heejun Chin. He's CEO, founder, director of Shin's Disaster Medicine Academy in South Korea. He's an emergency medicine physician and associate professor of emergency department at Soncheon University of Bucheon Hospital in South Korea. Has a disaster medicine fellowship at Beth Israel Deaconess Medical Center and a research fellow at Harvard Medical School. He has many contributions in preparing journals and responding to conventional cyber disaster and counterterrorism medicine. So let's welcome Prof. Shin.
Hi, folks. Thank you for your wonderful introduction for me. Today, I'm going to present about crowd disasters and countermeasures, but mostly the crowd disasters will be listed as just one table. Today I just want to deal with the 2022 Korean Halloween, Itaewon Stampede disasters. Okay, this is my affiliation. I mean, recently, a few days ago, I got appointed as a director of the Suncheon-yang University Hospital Disaster Medicine Center. So we are now setting up. So homepage is under construction. But since Disaster Medicine Academy, I have our website. So if you have any interest on it, then please feel free to visit. Okay, mass gathering medicine. I mean, I think you will know the expert about this kind of expertise, but I mean, I listed it according to the definition. So the concentration of people at a specific location for a specific purpose over a set period of time, and which has the potential to strain the planning and response resources of the country or the community. And let's look into the stampedes. I mean, there are several descriptions about the stampede. So, I mean, disruption of the orderly movement of crowds and leading to injuries and fatalities, often in response to a perceived danger, loss of physical space, or a will to attain something seen as gratifying. So, this can be described like this. Stampede usually 7.75 times higher fatality rate in low-income countries. Also, 40 times higher stampede fatalities in mass gathering that were unplanned. Okay, this is my analysis. This is not published, so preliminary data. This is a top 10 global mass gathering, crush and stampede incidents based on the EMDAT, that means the International Disaster Database, from 1900 to 2023. So this is the all over 10 list. So previous time, as mentioned earlier, I mean, in the Saudi Arabia in 2015, Mina, so total death is 2,300, and number of injured 805 was recorded officially in the data set. So about our, in Korea, 2022 Itaewon disaster, stampede disasters listed upon the number 4. So, I mean, total death recorded as 159, and number of injured recorded as 150. And from the October, 29th to the 30th day of October, like this. And among the data, India has 3 times about top 10 stampede history. Okay. This is the oil painting of that Itaewon district area at the Halloween. Yeah. And this is the real picture after the event at that day. Our president, Seong-yeol Yoon, visited the spot. And also, a few days ago, I think you will know that our president visited Saudi Arabia a few days ago. Yeah. So, anyway, at that day, look at his face. Yeah, he was alarmed. Yeah, too many young people died dead at that day. There was a great social, that gave us a great social, a shock for all of us. So let's look into the pre-incident alerts. And on October 29, between 1817 and 1826, within a few minutes, 2 reports mentioning a potential stampede were received. In 1834, another report was received indicating a possible stampede scenario in the alley in front of the Hamilton Hotel. Where crowds from Itaewon Station and people lining up for clubs were mingling and cheating, creating a potential hazardous situation. So for about 4 hours, from 18 p.m. and 22 p.m., a total of 79 reports were received before the incident. This is the picture right before the incident. Please look at that. I mean, there's a slope over there, up to down, and so many people are crowded at the space. And if you look into that more specifically with the up portion area, then some crowds look like they are being pushed by somebody in a row. So crowded alleyway where most casualties occurred shortly before the disaster. Incident occurred. So at around 22:15 on October 29, the stampede occurred on a downhill alleyway located west of the Hamilton Hotel in Itaewon. A large crowd was present in Itaewon due to the upcoming Halloween festivities, and the narrow sloped alley near Hamilton Hotel became the main point of the stampede incident. So this is the picture of that area. So this is the area incident happened right beside Hamilton Hotel. So immediate in the aftermath, following the stampede at 23:19 p.m., the firefighting authorities requested a halt to the festivities. Yeah. So this is the incident scene picture of that. The yellow tent over there is the incident command center in front of the incident places. So a lot of crowdings, yeah. And at that day, also the journalists gathered together and reported the scene situation without any masking. So many of the Korean people directly saw that kind of catastrophe in front of the television. Rescue and recovery efforts. So many resources, assets were mobilized. Yeah, there are so many assets mobilized. In Korean society, national incident management systems, usually firefighting or rescue first responders, were dispatched at the scene. And then if they require another reinforce about that, then public health sector rapid response team and also the regional disaster medical assistance team that is similar to the third team in the USA. This can be dispatched to the scene. So as you can see, 14 disaster medical support teams from Seoul and from Gyeonggi district surround the Seoul, so very near to Seoul district. Were dispatched along with 94 pieces of equipment, 222 personnel provided by ambulance teams from other provinces like this. But look at this, please. Very crowded, and ingress and egress were not coordinated properly. Okay, this is the pictures I mentioned about that. So this is a DMAT. The patient rescued. Yeah. So casualty total about the disposition, total 354 individuals were as a collected as a statistics. So 158 deaths and 196 injuries were recorded officially by the final official update by Korea government on 2nd December 2022, by the Central Disaster and Safety Countermeasures Headquarters and Ministry of the Interior and Safety in South Korea. Among the injured 196, 2 are hospitalized, 194 have returned home. Unfortunately, until so far, Korean government classified the specific numbers and data about patient data for the reason of the national security. So they prohibit to assess about that. So I didn't get any of specified data from them. Many corpses are covered by the blue curtains. So this is the official data. Epidemiology of death toll. In the gender, among the 158 deaths, female consists of 102. Age group and 20s are the most, 106. Death toll by region, Seoul and Gyeonggi-do around Seoul district, account about 105 among the 158. So there's issues of Itaewon Stampede disaster investigation. One is numerous unauthorized structures exist. At that time, Hamilton Hotel constructed illegally, expanded their outer wall, to the road. And also, population, crowding, estimated 8 to 10 persons per square meter, slippery and sloped load by alcohol and domino effect. The inadequate response by the police. There are so many detailed stories about it, but at that day, in the pre-incident alert, police got a report to reinforce the police dispatch to that place, but the head of the police denied. So after experiencing this catastrophe, he commits suicide. Okay, this is the road. Typically in Korean road, that kind of road should be at least over 4 meters, but that was 33.2 meters. Because the Hamilton Hotel, the left side, expanded their outer wall like this. And publication after the event, unfortunately, no white book released yet, even though 1 year had passed. And only one case report, SCI length case report was reported. So right on that, injury to the left side and about rhabdomyolysis, traumatic compression. So let's look into, I'm sorry, but I think I made some mistake to make time. I'll to kick process. Basic physics principles, that definitions we need to know. Density of mass gathering, the number of people per unit area is important. So physical interactions are jammed, crowded, add up, and cause dangerous pressure up to 4,450 Newton per square meter, which can bend steel barriers or push down brick walls. And this kind of forces can be generated by the 6 to 7 people pushing in a single direction, can be generated. So this is the survivor injury pattern. You can see the trauma injury, purple. And also we need to know about the nozzle effect. Nozzle meaning converging, diverging structural design in which can make a nozzle effect. So the rate of flow, speed, direction, mass shape, and all the pressure of the stream that emerges from them. And also we need to know about the proxemics. It refers to the human use of space and the effects that population density has on behavior, communication, and social interaction. So let's look into the counter measures. Focused crowd control methods must be practiced, and particular attention should be paid clearly, making pressure point. Balancing crowd dispersion and offering reliable ingress and egress routes to rescue personnel in the event of an emergency should be mandatory. And also to prepare for possible communications failure, we need a cell phone override codes, dedicated landlines, and prearranged radio frequencies. And nationwide campaign in disaster preparedness management is required. Expansion of the bottleneck infrastructure should be considered and implemented. Establishing single direction traffic, automatic visitor count, systematic scheduling, routing, these kind of things will be really important. And pre-planning, including the possibility of a large-scale disaster with the mass gathering risk assessment framework tool, should be implemented at the same time. Fortunately, I mean, Saudi Arabia made a great contribution to that. So Saudi Salem tool and Jeddah tool, made us a great alternative. Think about. So you guys will use this kind of stuff as a workshop, I know that. So I'll skip over. System-based approach is required. I'm sorry. What's up? Oh. Mobile field hospital operation, immediate field to hospital notification, access to a system nearby triage station, etc. Comprehensive events database development, and formal reporting standard parameters for inclusion in existing international disaster database are required. And I'll skip over the Jeddah tool, or they all make us to predict or to do some, give us some guideline to do some. Especially in the Salem tool, severe risk events can propose the restructuring, changing, moving the event site, postponing or rescheduling or canceling the event. So that will be very helpful, I think. But this is the last slide. Thank you. I mean, there's some also evidence-based scientific research was done in 2019. So one of our alumni, Abdullah Al-Dehaira, published the use of dimensional analysis in the XYZ axis to predict occurrence of injury in human stampede. So because of the time limit, I'll skip over. So if you are interested in it, then please look for finding. This kind of measure, especially Z-axis means over there, or right lower quadrant of the vectors. If the patient going up or going down in the crowd, then we can think about, it's very close to the human stampede. This kind of technology, a concept can be applied to the AR or CCTV, AI-based module can be developed, I think. So this is what I prepared. Thank you so much for your attention.
Thanks, Prof. Chin, for this interesting talk. Our next speaker will be Prof. Faris Al-Lami. He is the head of Department of Community and Family Medicine, College of Medicine, Baghdad University. He held many positions such as Director General of Public Health in Iraq Ministry of Health. He's a chairperson of Iraq National Immunization Technical Advisory Group, chairperson of the Scientific Council of International Academy of Public Health, and advisor of Iraq Field Epidemiology Training Program. He worked as a public health consultant for WHO, UNICEF, World Bank, US CDC, EMPH Network, and others. So let's welcome our next speaker, Prof. Al-Lami.
Assalamu alaikum. Thank you, Mr. Chairman. Thank you, Mr. Co-Chairman. Dear colleagues and friends, I would like to highlight the experience of Iraq with mass gathering, considering the Arba'iniya mass gathering that's located every year and had in Karbala city in Iraq. It is considered now as it is the largest peaceful mass gathering in the world indeed. Because it attracts, particularly this year, more than 22 million individuals coming from different parts of the world. Definitely the majority of them are from Iraq, but this year in particular, more than 5 million individuals had come from different countries, mostly from Iran, Pakistan, Afghanistan, many Gulf countries, as well as some other Western countries, African countries, and others. Arba'iniya mass gathering really marks the 14th day after the death anniversary of Imam Hussein, the grandson of Prophet Muhammad alayhi salatu wasalam. That's had happened almost 1400 years ago. And still people are coming to Karbala city, the scene of the event, and to commemorate this event. Definitely this huge number of attendees to this particular mass gathering carries a lot of potential health risk, not only to the attendees of the city, but also to the visitors coming from different parts of the world as well. It also makes a big challenge to the health system as well as other aspects of services provided in that city. This is a nice picture that had been developed from The Guardian. It is considered as the best picture for the week at that time. This is reflect the first people who came walking really from the most southern part of Iraq, from Fao city, which is located on the Arabian Gulf. They started this march toward Karbala, and they moved something like walking for something like 600 kilometers. And they started usually at the beginning of Safar, the Arabian calendar, the Hijri calendar, the beginning of Safar, and to commemorate at Karbala at the 20th of Safar, which is the time of Arba'iniyah. And you can see those are the first visitors, and after that people will come from different parts of the country. Here in this map had been developed as part of a study that had been conducted in 2020, where we do real-time surveillance of communicable disease, NCDs, and other health events in different parts of the world. And you can see these dots reflecting the sentinel sites for surveillance of these diseases. Definitely these are not all. It is less than 10% of all the health outlets provided these services throughout the roads to Karbala city. Is there a light? There is no light, I think. Okay, so you can see different, the people came from different governorates, from the south and mid governorates in Iraq, and also from some of the northern part or the governorate northern to the capital Baghdad, as you can see, and then they will go to the city of Karbala. I don't know if there is a light here or not. Okay. So all those people usually come walking for hundreds of kilometers till reaching the site or the city of Karbala, which is the scene of the event. Definitely many others use cars, others use other mode of transportation. Those coming from outside the country definitely use the airplanes and so on, and can use the country border as well with Iran, with Kuwait, with Syria, with Jordan, and others to commemorate at this area. And you can see this is these are the scenes where usually, I'm sorry for the quality of the picture, but you can see all those people. They are at the end will be within this very small area, less than 100 kilometers, a square of less than 100 kilometers, exactly 700 meters. And that's because it is very difficult technically to have all those people in one area at one time. This area, instead of making it on one day, which is the Arba'in or 20th of Safar, they usually extend the visit over 10 days. That's from the 10th of Safar up to the 20th of Safar, and after that everything will be subside and come to an end. In addition to that, the people who came from outside the country, and as I mentioned this year, for example, they constituted more than 5 million, usually stay in the country for 7 to 10 days. They will visit some other cities in Iraq, mainly Baghdad, Najaf, and Samarra, in addition to Karbala. In that study that we conducted in 2020, this is I made this map to highlight some of the countries that come. So these numbers are not the numbers of the visitors. These are the numbers of the patients who attended the health facilities that are on the way to Karbala, and definitely you can see that the bulk was from Iraq, and you can see large number come from Iran, Bahrain, Kuwait, Pakistan, Lebanon, India, Oman, KSA, Syria, Afghanistan, and many other countries as well. My point here is that I think that with having such a huge number of people coming from different parts of the world within such a small area, within such a localized time period, I think this can carry a considerable risk, not only to the people of the country, but also everywhere indeed. So we consider that as a risk for the global health security, because within this time there is a possibility of transferring our transmission of different diseases, which will not develop at the time where they are in Iraq most of the time. Because of the incubation period, we will expect that these conditions will be developed later on after the incubation period. And to be honest, some events had been recorded and had been published as well. In the MMWR, for example, there were reports of MDR salmonella cases that were developed and attended in Iraq, and after that they appear in UK and in USA. So we have to give the attention to this important mass gathering. The important health risk that we usually face during such an event is the communicable disease outbreaks, definitely, which is the most important indeed. And in most of the projects that we conducted on real-time surveillance that we conducted in 2014, 2016, 2018, and 2020, with the support of the Eastern Mediterranean Public Health Network, really INFNET, we used the surveillance syndromic approach in order to identify the most important syndromes that we are afraid of in the country, mainly diarrheal diseases, acute respiratory infections. Hemorrhagic fever is a considerable risk that we are always concerned about, and this year and the previous year there was a big outbreak of Crimean Congo hemorrhagic fever in the country, so we always consider that. Also, exacerbation of acute complications of different non-communicable diseases, because large number of people with non-communicable diseases, they come to this event walking and disturbing their dietary habit, their intake of medication, walking for such a long distance. Definitely this can carry a considerable risk for acute complication of the NCDs. And definitely weather-related condition, because here this event follows the lunar calendar, so this event can happen at winter time and at summer time. So weather condition is extremely important, particularly in Iraq, where Iraq is facing a considerable, extremely high heat, and I'm sure you hear about most of the times during summertime the temperature is more than 50 degrees Celsius, and for those walking on the street without any covering and so on, the temperature can reach up to 60 degrees Celsius. So you can imagine the health risk that those people can expose to. Also, different types of injuries. Almost all kinds of injuries had been reported in the previous years, but on the top of that is the road traffic injuries. And yet last year, for example, the number of victims that are affected by the different kinds of injuries were almost 5,000. 499 end with death. So it is almost 10% case fatality rate as a result of only the injuries in these events. Some other risk, safety risk, because of the overcrowding, uncontrolled movement of large crowds in case of accidents. You can imagine from the picture, how can we mobilize, how can we move a patient, for example, if he develop any kind of event, how can we send him to the nearest hospital? In fact, some solution had been made for that through training of some people to provide the first aid for those people and then to transfer them later on to the nearest health facility. This year, 28 events of ischemic heart disease had been developed among those and had been transferred to the nearest hospital, and thankfully all had survived. Also, stampedes and leading to mass casualties and deaths, and this happened several times indeed. Like for example, in 2015, a big stampede had occurred. Also, security risk, as you all know that during the
2005, 2006, 2007, Iraq had been exposed to a lot of terroristic attacks, and after 2014, the ISIS invasion also ended with a lot of terroristic attacks. So always this event considered as a target for terrorism. And it happened indeed. Several times, several terroristic attacks had been reported in these events. The health services that are provided are not up to the standard, but still we think that there are certain opportunities that we can build upon. Among these, and number one is the positive attitude of the population. As I mentioned, that all those people, or probably I didn't mention that yet, the 22 million individuals this year, and last year it is almost 21 million something, all those, they are being provided with the food, drinks, accommodation, other services, including laundry services, internet connection, etc., are provided free of charge from the civil society, from the general public. The government is concerned with the security issues, with transportation to a certain event, and provision of health services also to a certain extent, because the civil society also engage in provision of these services as well. So you can imagine all those people had been served by the general public for all the days that they will spend in the country. So the interest of different sectors is also an opportunity that can we build upon. In the incredible participation, as I mentioned, of the society and the general public, the presence of the reasonable infrastructure that was built over the previous years, the presence of the available trained personnel, and the lesson learned from national, regional, and the global legacy. The Hajj, for example, is a good example that we can use and we can learn from. But still we have a number of challenges and gaps. Number one is the security concerns. Although at these days, these security concerns have been decreased significantly. And every year we do the risk assessment using the JIDDA tool, and we demonstrated the risk is there, but definitely it is less than before. The inadequate coordination between the governmental and general public efforts, again, this can probably make the result is not up to the optimal level. The inadequate contribution of countries sending pilgrims. Here in Hajj, for example, there is a wonderful collaboration and coordination between the countries sending their pilgrims to Hajj. But this is not the case, unfortunately, in Iraq. Although some efforts have been made with Iran, for example, but I think more efforts is still needed. And limited studies highlighting the strengths and the gaps, and to generate evidences at the end. Also gap in some legislative packages, particularly at the point of entries. Although a lot of instructions have been made from the Ministry of Foreign Affairs to the point of entry, but unfortunately this is not applied all the time because of the substandard control and the command system in general. And fragmented response activity and lack of adequately detailed guidelines and SOPs, and the substandard mass gathering surveillance system, as we will mention soon. So the way forward, we think that establishing a designated mass gathering control and command system and emergency operations center, again, concerned with the MG, is a mandatory. Enforcing multi-sectoral collaboration at the point of entry under the IHR is another important area, and it had been demonstrated in the external evaluation of the IHR. There is a gap in this area. Development and implementation of guidelines and SOPs considering the national context. Review and revision of the Public Health Act, which is it is almost 40 years now old, and the work is being done in order to revise it, enforcing the existing regulation and formal training of the workforce, particularly at the point entry regarding the MG-related efforts. Strengthening transborder collaboration and the collaboration with the neighboring countries and countries sending their pilgrims. Expanding surveillance system. Currently the surveillance system, as I mentioned, it is a syndromic, but we think that the engagement of the laboratory, One Health, digitalization, and post-event surveillance is a must in order to understand the condition. what happened during the MG, strengthening health auditing and assign adequate and dedicated fund for support of MGs. In fact, last year, with the support of INFNET, we reviewed all available literature concerned with the mass gathering in Iraq. And after that, we end with some policy briefs that have been submitted to the Ministry of Health to consider as a roadmap for improvement of the response to that mass gathering. And in summary, establishing an MG public health body within the Ministry of Health, which closely involved with all the relevant departments from Ministry of Health, and establishing a permanent MG council within the cabinet in order to oversight and coordinate all the activities run by different stakeholders. Well, promoting multi-sector collaboration among relevant governmental and non-governmental sectors for concerted efforts and respond to potential threats. And lastly, operationalize the MG emergency plan to respond to different CBR and threats. Thank you so much.
Thank you so much, Prof. Faris, for excellent talk. Grade 3 experience we had from our respected speaker. We'll continue the journey with 2 more speakers to go. Allow me to introduce Dr. Valerio Mogini. Is an emergency medicine consultant and a senior medical officer, staff of medical direction of regional emergency health agencies, coordinator of regional task for monitoring patient flow. He held many positions at the Italian Red Cross, such as head of services for emergency health organization, health emergency response consultant, and health services coordinator. So, ladies and gentlemen, let's welcome Dr. Mogini.
Thank you for the presentation, and thank you, everyone. Good afternoon, and I will talk a little bit about the organization in Rome, about the Papal Mass, and the role of the Italian Red Cross in this topic. First of all, I want to start giving you a little bit of an insight of what the Red Cross is, because although we all know the Red Cross national societies, and in our countries there's one, we probably are not that much confident with the movement itself. I mean, movement is it's made of the national societies, the International Federation of the Red Cross and the Red Crescent, and the International Committee that is based in Geneva and has its mandate in war zone. Why I'm saying that? Because this obviously to us, as Italian Red Cross, we are part of a movement, and we are as part of a movement, we need to respect some principles that are at the basis of the movement itself. In the Red Cross, those are the principles that we follow, and one is, of course, 4 of these principles are the basis of the international humanitarian law, and 2 more applies to the Red Cross national societies, which is the unity, the fact that in one single country there can be only one national society of the Red Cross, and the voluntary service. Voluntary service is something that is very important to me in this moment, as our staff is actually the volunteers, as this is something that is very positive, because it means that we can rely in this kind of occasion in people that are donating their time. It also means that we need to tailor the education and the learning for these people, and trying to set some standards that must comply with national and international regulation as well. And applying these to the volunteers' world, it can be sometimes tricky. I must say that as National Society of the Red Cross, as the Italian Red Cross, we are also part of the Civil Protection Department, and this means that we need to apply also the training of the Civil Protection Department. And getting back to a theme that yesterday was an animated debate, I would say that we are following mostly the MEMS standard as a European country and as part of the Civil Protection Department. Before going to the papal mass gathering events, I want to tell you something more about the city, because of course something that popped out in this discussion is the fact that when you are facing and when you are thinking about how to respond to an event, you need to understand and to define whether the specific aspect of that event. In this case, of course, the geographical area and the system and the services are pretty important. Rome is the capital of Italy, and the urban area population is about 4 million people. In 2019, and I'm using 2019 because of course figures after COVID and in the COVID period were a little bit different, can host and usually host 15 million tourists per year. 2023 marked a plus 5% of tourists in the Rome area. It means that's a quite crowded area, and the tourists obviously are mostly located into the city center, and so that is the most sensitive part of the service and the system. Something else that I want to say is the system that we are working within is a public universal health system that ensures healthcare to any citizen, but also to any person that are on the state and on the field. So it means that if you're a tourist in Italy, you will be given free care in case of emergency and in case of public health concern. So those two areas are fully covered, and this is something that is very important. It means that in planning the events, when responding to an event, we are responding as a whole. Health system, law enforcement, and hospitals, they're working together. Emergency medical services also are governmental, and as the Red Cross, we are auxiliary to the public powers. So it means that we are supporting and we give our support to the national authorities. So this is something very important to understand, and also the fact that the hospitals themselves, even if they are autonomous, they work as a whole, they work as a system, and the regional authorities, of course, as authority over the hospital. So they are not working for themselves. They are not, I mean, there is always a planning that involves the whole services in the area, and this is very important. Those are the hospital with an emergency department in Rome. I kept the Italian name DEA, which means Department of Emergency and Accident. The second level is considered the highest one, with operating intensive care and specialty intensive care and specialty and subspecialties 24/7, while the first level, they can ensure intensive care presence and emergency surgery, obviously, and some subspecialties 24/7. Basically, then we have emergency departments that are not into this kind of, that are providing only emergency care, but might have a lower level. But as you can see, they are quite spread over the city, and we also have two pediatric centers. Of course, all the hospitals can host and are able to treat pediatric cases, but we have two only pediatrics hospital that can also manage trauma and emergency situation, and this is and they are part of the system as well. The system is organized into a hub and spoke service. So it means that obviously the first tier, the first level can refer to the second level and to the third level in a predetermined fashion. And this is obviously something that make the process of managing also the big events and mass gathering events. So this is the going a little bit through the organization and the data about papal mass and how we do deal with that. This is the geographical area of Rome. You can see that there is something very peculiar and something that we need to consider when thinking about papal mass. The fact that we are talking about a different state. Although Vatican City is inside Rome, is indeed a different state. Does mean that the management and organization should be done within the Italian state authorities and with the Vatican authorities, and those are not all the same. So there is agreement. There are agreements between the two states on how to manage what is happening in the square and in St. Peter's Square. As you can see, and this is important, I will show you later why. As you can see, Vatican City is very close to an hospital, but that is a first level there, so not the highest. It's a small hospital, but then is also pretty close to the Policlinico Gemelli in the north and Policlinico Umberto I, which are two university hospitals, and two other second level there in the southern part. And the one next to the Colosseum is also very important because it's San Giovanni Hospital, and San Giovanni is also a church where they, in case of big events, well, sometimes the Papal Mass can be in San Giovanni, but when the number of people out, I mean, there are too many to be contained into Vatican City or in the part in front of St. Peter Church, San Giovanni is also used to host the events. A Papal Mass usually gather between 50,000 up to 200,000 people. The St. Peter's Square can host 300,000 people. So usually the square is not that full, and usually this number are can be managed in a quite easy way for the city. Those are not a problem. This is something that happens almost every Sunday. So the Papal Mass, there is a Papal Mass every Sunday usually, depending on the condition of the weather, depending on the condition of the Pope and the social condition. Of course, the number of the people can be different, but usually the most crowded moment is Easter time and the Easter Mass that usually gather 200,000 people. But today I'm not going to talk about that. I'm going to talk about another standard, which is the beatification of John Paul II, because these are something that happens every year and that can be quite managed in an easy manner and with the usual system that is in place, because it happens every day. But obviously, there are some specific moments in which the thing can be different. I want to show this is the square, and what something pretty important is that at the end of the colonnade of the St. Peter's Square, it starts the Italian territory, but inside the colonnade is Vatican City. So it means that no EMS from Italy, no police from Italy, no Red Cross can enter that square. It is Misericordia, which is a voluntary association organization of the Vatican that is taking care of the people inside the square. We work outside the square, and I will show you where. So just to let you understand how we need to move and to think about the events according to the specific moment, I want to show you 3 different moments. This is Easter 2020. That would have been a crowded square, but this is the image from COVID. So the Pope alone in the square, quite a powerful image. This is the square on 2023 Papal Mass. It's crowded, but as you see, there is the possibility to move within the square. The person are kept into some area, and there are safe ways to escape and to move in any moment. This is the St. Peter's Square and Via della Conciliazione, so the whole geographic area that we saw before, the day of the beatification of John Paul II. 1.5 million people gathered together that day, because it was a weekend, and of course that was a highly coordinating planning with the Vatican representatives, with EMS, the health authorities, and NGOs and the Civil Protection Department. As you can see at the end of the colonnade in this image, you will see some tents amidst the crowd, that is the place where you can have the contact between the person and the people that are acting inside the colonnade and outside. And we usually use that part and also the streets around for the sanitary services. As the Italian Red Cross, we in 2014, this is what we deployed to support the operation. 23 ambulances with medical staff. It means 3 people in every ambulance, a doctor, a driver, 4 people, a volunteers, a paramedic, nurse, doctor, emergency doctor, and the driver. And drivers are also paramedics in the Red Cross. 33 ambulances with nurse and paramedics, so without the doctors, to stabilize and maybe transport the ECS cases. 43 working teams made up of 3 volunteers trained in first aid and BLSD and carrying a defibrillator with them. So it means that they could go within the people, within the crowd, and ensure that a prompt and quick response would be given if needed in any moment. Our volunteers are all trained in also our health volunteers. I mean, we're not health people, but health volunteer. They're trained with BLSD and also with emergency management and emergency awareness classes based on on memes, so that they can understand where they are going, what they are doing, and how they are working, and also the chain of command is pretty clear inside the Italian Red Cross. So along with that, 15 bike teams, obviously to go through the crowd, an emergency care unit ambulance, 2 medical cars staffed with 1 MD and 1 nurse, and 1 advanced medical post with 8 bed capacity run by anesthesiologists and intensive care. So that was in Piazza Risorgimento next to the St. Peter Church, so to stabilize and to observe patients in case of need. And 1 medical post for not critical cases, and something that I'm proud to say that we also deployed safe point for maternal support and psychosocial support. Maternal support, this safe point were supplied with all that was needed for breastfeeding, all that was needed to wash the babies, to clean the babies, to give some relaxing moment, because of course the crowded places could become a little bit too much for families, and of course Papal Mass would put together, would attract families and many kids and many people that might need this kind of services. And psychosocial support is always needed, is always very important, because although people are having a good time, that might become difficult, or sometimes it can become hard to deal with the pressure of having 1.5 million of people around you. Everything was coordinated by a mobile EOC that would coordinate with the local authorities and with the civil protection, and would be the point of contact with all the other organization. Team leader is always identified into our staff, so that the communication can follow a predefined flow, and everyone knows who is in charge and who is need to be called for the response and to give information. This is just the outcome and some pictures of our volunteers. In that day, more than 2,000 people were treated at the medical posts. Those are the triage code that we found out. And 900 people had been transferred to the hospital for observation or for treatment. That means also quite a huge burden on the system that needs to work together, and also on the hospital system and on the hospital services. Concluding this, I want to just state the fact that what you need, of course, is a situational awareness. You need to imagine what can happen. You need to know the people that you're going to treat and the people that you're going to gather together, but also something that can make the difference, are the relationship, of course, with the government, with the state, with the system itself, but also something else, which is the history of the one who are performing and the capacity built on the experience. This is pictures from 1939. That is an Italian Red Cross tent. That is the colonnade of St. Peter's Square. So we had been doing this for almost 100 years now, and we look farther to do it for 100 years more, obviously continuing putting an effort on education and learning and learning of our volunteers. Thank you.
So thank you, Dr. Magini. Please let's welcome our next speaker is Captain Dr. Ali Az-Zahrani, Head of Epidemiology Unit at Preventive Medicine Section, King Fahd Armed Forces Hospital, Jeddah. He has a vast experience in mass gathering and has served in many Hajj sessions and served with medical team in the war with Yemen, and lastly was involved in Kingdom's humanitarian evacuation of foreign nationals from Sudan to their destination safety. So Dr. Ali will give us a brief of his experience in this big event that occurred to evacuate patients and surveillance from Sudan. So let's welcome Dr. Ali.
بسم الله الحمد لله والصلاة والسلام على رسول الله. الحضور الكريم، السلام عليكم ورحمة الله وبركاته. ابتداء نود أن نشكر المؤتمر العالمي لطب الحشود لدعوتهم الكريمة ومشاركتكم عمليات الإجلاء من دولة السودان التي قامت بها القوات المسلحة السعودية. I will start to talking about the effort of the armed force of Kingdom of Saudi Arabia in evacuation from close brotherly country of Sudan. As you know, Sharia evidence and international law combine together to prevent the aggression against civilians and people who are remained neutral or have no aptitude for war, and they don't join fighters in the plan or with similar other way. And the people are called civilians in the current terminology. Parties of conflict must protect them from some of consequences of war, such as the effect of hostilities, restricted access to food or water, and lost links of their family and a loved person. Because the human comes first, the commands were issued by custodian of two mosques, King Salman bin Abdul Aziz, may God protect him, and Royal Highness Crown Prince Mohammed bin Salman, God protect him, to carry out the operations of evacuation of citizens and number of citizens of brotherly and friendly country, including diplomats and international officials from Sudan to Saudi Arabia. We present below brief summary of evacuation process have been performed by Health Service of Armed Forces. 21 travels were carried out by Royal Saudi Naval Base forces with participation of the ships of His Majesty the King Jubail, Dir'iyah, Riyadh, Mecca, Abha, Taif, Yanbu. 7,925 people have been evacuated, residents and neighborhoods of friendly country. A total of 1,116 sailing hours completed. The traveling distance is 9,626 naval miles. The duration of trip from the King Faisal Naval Base to Sudan, to Port Sudan, is 8 to 12 hours on the same day. 6 flights were carried out by Royal Saudi Air Forces. 530 people, citizens and citizens of brotherly and friendly country, were evacuated. 26 foreign flights were received through King Abdullah Air Base in Western region, and 22 flights departed by foreign airline. For the medical and preventive procedure implemented by the medical staff represented by the Health Service of the Ministry of Defense, we make sure that all ships and aircraft are well prepared to receive citizens and nationals of friendly and brotherly country by providing necessary tools and supplies. We set emergency plan to deal with the emergency and infectious cases, and coordinating through the operation room equipped to communicate between military bases and King Fahd Armed Hospital in Jeddah. fully prepared that the health clinics, medication rooms, as well as readiness of health staff, handling the creation of appropriate health environmental situation, and the presence of qualified team specialized in food safety. All those who were boarded on the ships and planes have been sorted through visual and thermal examination for the consideration the spread of the epidemic diseases in Sudan, including the spread of yellow fever, malaria, meningitis, and dengue fever. Preventive measures were applied to all borders, isolating suspected cases in isolation room until the arrival to Saudi Arabia to complete treatment and follow-up, starting immediately with cases that required necessary treatment in medical clinics inside the ships, and evacuated cases that need for urgent intervention via vertical aircraft located in ships. Upon arrival in Saudi Arabia, all suspected and emergency cases were transferred via fast and safe passage to the hospital of the Ministry of Health or King Fahd Armed Forces Hospital in Jeddah, through participation of Saudi Red Crescent and Armed Force Health Service ambulance to provide the necessary health care and transfer them to residents organized for them and follow up on the health condition. All of this was done according to coordination and integration between all sectors. This picture for our colleague, and you can see the dealing with the different age group, the pediatric, old age, bedridden patient, and bad psychological emotion for them regarding to war, and deal with them by qualified and professional way. Our challenges, the limit time of implementation of evacuation and frequency of flight, dealing with the different language and nationalities, dealing with different age category, children and elderly, in addition to some pregnant women and bedridden patients, the poor psychological condition of those arriving during the evacuation process due to condition of war. Success factor, unlimited support from the wise leadership represented by custodian of two holy mosques, King Salman bin Abdulaziz, may God protect him, and His Royal Highness, the Crown Prince Mohammed bin Salman, may God protect him, the fully equipped of armed forces in all time as a result of practical and continuous exercises. Full coordination among all sectors of the participating armed force and Ministry of Health. Here, this is video produced by Ministry of Defense, simulate the evacuation process. I hope it's working. 5 minutes from your time.
الاشتباكات متواصلة منذ أكثر من ساعتين أو ثلاثة، وما زلنا نستمع إلى أصوات ونستمع أيضا إلى أصوات المواطنين الذين يرفعون الصوت، ولا بد من حسم ما يسمونه بالخطة وصلت إليها.
السلام عليكم، سفارة السعودية في الخرطوم، كيف نقدر نخدمك؟
أصدر الديوان الملكي اليوم بيانا أعلن فيه أن غدا أول أيام عيد الفطر المبارك.
محمد، خذ الأغراض من أبوك.
عليك السلام ورحمة الله. سم، الحمد لله بشرك بخير ونعمة. سم، طال عمرك.
وش فيك؟
العمل. يقول غسل وجهك ولا تنشف اللي عندي.
يلا توكل على الله، ترجع لنا سالم غانم إن شاء الله.
غسل وجهك.
اطمني يا نور، في 3 سيارات من السفارة بتكون عند بابك.
كم يبي؟ البيت كله قاعد يستصحون.
خليك جاهزة مع أغراضك عند الباب. الطريق لك الآن 3 سيارات طريقها لك.
وصلني تحديد الأسماء، اسمها نورة، معها طفلة رضيعة، استعجل بالله قوتنا بتوصل أمينة بأي لحظة. عمليات جميع الأطقم مستعدة للمغادرة إلى ميناء بورت السودان.
إلى علوم الطاقم نبحر الآن سفينة جلالة الملك الدرعية إلى ميناء بورت السودان لبدء عملية الإجلاء.
نحن بالقرب من نقطة النزول، يرجى من القوات الخاصة الاستعداد.
اسرع يا نورة، زيارات السفارة عند بابك، قواتنا متضاربة في الميناء.
وصلنا بالسلامة حبيبتي.
on 20 of May 2023, the Saudi Foreign Minister announced that, with God's help, the evacuation process has been completed successfully through concerted effort among all participating forces. And thank God, there was no outbreak of infectious disease and no injury was observed during the evacuation process. We affirm that the success of armed forces in carrying out evacuation has highlighted their readiness and ability to deal with any emergency according to the highest level of accuracy and efficiency. And this comes from the awareness of our wise government and the directive of the custodian of two holy mosques and His Highness the Crown Prince, and with diligent follow-up of His Highness of Minister of Defense. Because the human comes first. Thank you for your attention and listening.
So thank you, Dr. Ali. Very inspiring and proud story for us. Good job. I have no word to say. That's really a good job. Okay. Now, so we concluded now our session. Now the floor is open for a question. If anyone have question about this 5 experience that presented by our respected speakers. Probably we have one question here. Yeah, in the middle. And a microphone or something.
Thank you so much, everyone, for the amazing presentations. Actually, that was all like an eye-opening. I have a couple of questions, actually. One for Mr. Julian, and the other one is for Dr. Valerio. So for Mr. Julian, so have you investigated actually why there were a breaking or non-sticking to the guidelines that was already implemented or was already there before the stampede happened? And my other question is for Dr. Valerio. So one of the things that we always talk about in disaster medicine is the medical legal aspect of the foreign help or foreign aid that goes to different countries. So how you deal with that actually, since the Vatican is not an Italian territory? Thank you.
So, Dr. Gidi? Yeah.
Thank you very much for the questions. So I think in the low and middle income countries, the SOP being violated because these economic reasons, no? Because they trying to get more benefit, more. I mean, they try to make more money from the business of the football industry. So they put like empty ambulance in the stadium, but like the SOP should be it's full scale ambulance for the athlete, but instead they put this empty ambulance because they think there's nothing, it's useless to put the ambulance there. And also many SOPs being violated because they think this business as usual. Nothing happened as usual, but when the worst come to worst, this is what we experience. So I think that's the reason. Thank you.
So Dr. Majidi?
Yes. Thank you. Okay, maybe it's working. No. Thank you. So thank you for the question. As I said, most of the operation carried out by the Italian side. So there will be the liability of the professionals would be under the Italian law, and also there are agreements between the Vatican City and Italy about this, obviously, and
basically, in any case, it's something that is not going to be about Vatican citizen, and Vatican citizen, of course, are quite a few that would be under the Italian law. So that would be the legal framework and the legal liability that we would face. The big issue might be, and it actually is whether the volunteers, the non-professionals, volunteers performing healthcare-related acts are liable or not, and can be liable for what they do. So this is another big point and another big question that all the association working with volunteers should think about, and this is mostly. So I would not be concerned about which kind of law is going to be applied, because it's going to be the Italian law and the Italian tribunal to judge them. But mostly about the liability of the volunteers and what they do.
Great. We'll take one more question for the time's sake. So if anyone have a question, that would be fantastic. Okay, so probably there's no more questions, so we'll conclude our session. I think if I sum up the all 4 talks, it will be preparation, communication, and learning from our experience for future preventive. Thank you so much. See you soon.
It's a group photo. So we're going to start our next session about the event experience. Please welcome with me Dr. Ali Sharif. He's an associated professor and emergency medicine and critical care consultant at the Military National Guard Health Affairs in Jeddah. He held the position of Dean of College of Applied Sciences at King Saud bin Abdulaziz University for Health Sciences. He received his emergency medicine residency at University of Manitoba, Canada, critical care fellowship at University of Ottawa, Canada, and simulation fellowship at Harvard Medical School in the United States. He also has a master's degree in disaster medicine. Our second moderator is Dr. Umar Uthman. He's an emergency medicine consultant at King Saud Medical City in Riyadh. He's a Saudi and Arab board certified emergency physician and received his fellowship in disaster and emergency medical services from Brown University, Rhode Island, United States. Currently, he is the director of EMS and disaster administration at King Saud Medical City in Riyadh, First Health Cluster, and the regional Saudi Board of Emergency Medicine Program Director. Dr. Uthman is involved in many developmental projects nationwide and many ongoing research for improving emergency medical services and disaster emergency care in the kingdom. Welcome, doctors.
Assalamu alaikum. Good afternoon, everyone, and welcome all. And I hope that you are enjoying the second day of this excellent conference. So we will continue the event experience with this session, and I would like to start presenting our distinguished speakers. The first speaker of the day is Professor Sylvia Dyer. She's a board-certified emergency medicine, EMS, and toxicology. Professor Meyer is at Boston University School of Medicine. She serves as the medical director of Boston EMS and the associate medical director of Boston Mid-Flight. She also served as a board member of National Association of EMS, physician and fellowship director of the Boston University EMS Fellowship. She has extensive experience with mass gathering, both large and small scale, with the goal of a safer events for communities. And she's a co-medical director of the Boston Marathon, and she will be presenting a Boston Marathon, which is the oldest marathon in the United States. And Dr. Meyer, please join me to welcome Dr. Meyer to the stage.
Thank you, sir, for that kind introduction. And thank you, everyone. I really appreciate the kind welcome here and the opportunity to speak a little bit about some of my experiences, both professionally and with sports. I also very much look forward to the wonderful panel ahead as well, and such great speakers from our prior panel as well. So I'm just going to talk a little bit about, I have no disclosures here. The views represented are my own. But I wanted to offer actually, so in 2013, we had a marathon, just like we have every year. And then we were the unfortunate victims of a terrorist attack, just partaken by 2 people, that resulted in 3 deaths immediately and then 2 subsequent deaths as well, secondary to that. So after that event, I actually had a chance to do a lot of reflection on preparedness, do a lot of learning and studying about kind of how we continue to prepare for mass gatherings. So I'm here to offer kind of within that context of a sporting event, but all the other kind of wonderful mass gathering events I've heard from you folks and the incredible experience from the Hajj as well as all the other panelists. Just a little bit of an overview of some thoughts I've had about mass gathering events since that time. So I'm going to actually, we're a relatively small city in Boston, just 1.2 million. But we have very frequent gatherings, around 1,000 a year from small to large. The Boston Marathon being one of our largest gatherings with a participation of about 500,000 people as spectators and about 36,000 people, up to that amount for runners. So I really want people to start to think about mass gatherings as within the context of emergency preparedness and the context of EMS as well. There's opportunities for community planning, as we've seen here. I'll also talk a little bit about partnerships and pitfalls, and then also mass gatherings as a leadership challenge. So we start our event every year. We have the same recurrent event, again with a lot of participants. Like most marathons or all marathons, it's 26.2 miles. There are a lot of people who begin a marathon who have no business being there, but there are charity runners and we support them as well. But really the marathon is a recurrent event similar to other events that I've heard about here that have the opportunity for some community engagement and community change as well. And this is actually another event that happens in Boston. It's our 4th of July ceremony. I bring up this event because you can see a little bit more of a crowd there, but the initial bombers had an attempt that was going to be their target. They were going to go after the 4th of July, which looks really slightly different than the context of a marathon. Thankfully, that did not happen, and they did not take out their plan at this event, but it would have been a lot different. But I still think a lot of the issues of how we think about security for all in mass gatherings. So I wanted to take a slightly step back from a very traditional academic view and take a view actually from an Australian who has this wonderful book, and it really is How to Begin. So if you're going to be starting a mass event, how to begin. And the context of the book, I think, really embody a lot of what everyone does here in this room as a mass event community to look at the various components. So those are, who are you traveling with? At what speed are you traveling? What commitments do you make to get this event done? And what tools are you going to use? We saw lovely tools here in all the different sessions. But let's put this into a further mass gathering context. It's really great to do what you love, and everyone here loves their mass gatherings, but really even better to do it with a wonderful team that you have. So taking the components of this book that I really suggest that you take a look at in the context of mass gatherings, who are you traveling with? So who are your community partners? Is it just a local event? It is a national event? Or is it an international event, like some of the events that we're going to be hearing about in terms of FIFA? At what speed are you traveling? Some mass gathering events, like rapid protests, happen quickly. Can we have an organized plan so that we can put together a plan for a rapid response? Or are we going to have more long-term planning for recurrent events? The events here that happen in Saudi are good examples of that, but really all over the world where we have recurrent events that we need to kind of learn from and plan from. And if I've learned anything over the years in mass gatherings, it's the planning for the next event really starts the day after the prior event just got done, in terms of your ability to collate and look clearly at what went well and what went wrong as well. What commitments do you want to get this done? Can we all organize as a team and commit to that? And I'll say, it really is a wonderful quote from our keynote speaker, no one's safe until we're all safe. And then the concept of no ego and no blame, and then what tools are we going to use? I love this saying, which is, plans are useless, but planning is essential. When things go wrong in an event, it's rarely that people are going to pick up an extensive plan. But if they were part of the planning process, that's actually the work. At the Boston Marathon, we have a planning process that starts year after year after year. And this is just our medical manual, over 88 pages long. But it's actually not the length that really makes the plan. It's really the hundreds of hours of collaborations with a lot of volunteers. We actually use Red Cross volunteers as part of our planning, and the vast majority of our medical volunteers are actually part of our community and can continue to be relied on for that. And then we also have plans for course disruption, weather, hailstorms, lightning, but also civil unrest that we can also see. And then after the bombing, we started some more planning and tourniquet packs, really upstaff the hardest part of any type of mass gathering, which is communication, and then some other MCI planning as well. And then it made MCI planning part of our routine. And this actually holds in good stead for other events like this, like a parade or a concert, or even some larger events where we put several million people into our city. I really appreciate our other lecturer in the papal space, Dr. Valario. This picture has no barriers, like you set up at the Vatican as well. Although you can say in the United States, we feel that American football is a religion, so perhaps some context of that as well. So this is a picture of the events that happened at our marathon that really gave us an additional context of mass gatherings in terms of a terrible event that can happen. This is actually the second bomb that went off, and 3 people died, but as well over 150 people injured, and probably even more so in terms of that psychological space as well of people that had had injuries. This was actually toward the end of the race. Had it been at the more earlier parts of the race where the crowd was a little bit denser, we would have even had more problems as well. So what are some of the principles of leadership in terms of mass gatherings, of all these events that everyone's heard today? And I think they really, for me, fall into several contexts, which is what we mentioned before. Plans are useless, but that planning process is truly indispensable. Connectivity counts, and I'm going to explain that. The concepts of swarm leadership, cone in a cube, and at all cost, avoid the basement. So all this doesn't make sense until we take it into context. So I take all these concepts from this really great book that I would suggest that you pick up if you have anything to do with mass gatherings at all. And it goes over these concepts. The first one is that connectivity. So in any mass gathering event, you're going to, you as the person in the middle, are solely responsible for what you're doing, but you need to lead across other units, lead up to your boss, lead down for you as a boss as well, but also leading beyond other organizations. And all of mass gathering is really that combination of all these other organizations. So I wanted to give you a couple of buzzwords that I've extracted from this really great book. And that vertical connectivity, how can we lead up and above? And if we have kind of a generosity of spirit, I love this phrase, which is, how can I help make each one of you a success? If we are focused on making the other part of the organization or the other part of another organization a success, we actually actively participate in that framing of a relationship. And it really is all these relationships that allow us to sustain and persist during a mass gathering event. But also leading across and beyond. So having that team building to foster unity of purpose, and then integrating across departments, units, and organizations. And we've seen wonderful representations of this throughout our time here at this wonderful conference. I would also say check your lens, right? As we all go into a mass gathering event, when we went into the events of 2013, we actually had a lot of preparedness beforehand, but our preparedness actually wasn't necessarily focused on a traumatic event. Our preparedness was because the marathon before in 2012 was uniquely hot, kind of in probably a climate change response type hot. And that actually got a lot of attention. We have this marathon every year, and sometimes I think there's always the potential to say, oh, we've got this, but it was that extra tension of the year before that I think helped all the teams, particularly the volunteers, but the rest of the healthcare system perform well. And really agreeing that everyone has a different perspective. The pre-hospital people have different perspectives than public health, and have different perspectives than the brick and mortar hospital. And this is another concept of that perspective, is the concept of the cone and the cube. We each look at a peephole differently, and we need to understand that everyone has a different perspective in terms of the concept of a mass gathering. And just to embrace that and realize that we have to at some point kind of agree that we all have a different view. And this is actually a framework of everything we've kind of talked about, which is for any mass gathering, I think you really need to have this unity of mission, generosity of spirit and action that we actually also saw in some of our most recent presentations, the willingness to help others, and really that idea of how can I help you be a success. Really important one that is sometimes hard to get around, which is that concept of no ego and no blame. If you look at this book by Marcus et al. From the first chapter really talks a little bit about the Boston Marathon event, and there's always within intergovernmental interactions a chance of kind of some headbutting and disagreement. But if we come at it a spirit of no ego and no blame, that if something goes wrong, we all take responsibility for it, we have that mental frame shift. And that mental frame shift actually ends up being our foundation of good relationships. And you cannot have a good mass gathering without a good foundation of relationships. Now, you also have to think about this in the context of where you are. And when anything goes wrong, right, something terrible happens at an event, things aren't particularly prepared. You have to think about it in these three contexts. There's always the chance of having that fight or flight or freeze response, right? Recognizing that when's that happening in yourself. Activate what you've prepared. So do you have a plan for this particular event? And how are you going to do this with the spirit of we can do this or I can do this? And then closing the gaps between what is, in terms of the situation you have at hand, and then what could be in terms of the best health and safety of everyone. And that's really where your laboratory is. And this is really represented again in the text of your metaphorical brain. So that workroom, that's what's happening every day, your routine patterns of working at your mass gathering or your emergency department, your laboratory, where's your creative thinking? How can we creatively think about our mass gathering in terms of being, having a solution-based approach to this? But then also realizing that we're all at risk of landing in the basement when we really start to get to our survival instincts, when things get really tough. And that's actually the place that you really want to avoid. Whoops. You want to avoid that in the context, the context of the basement. So it's not the fact that we go to an emotional basement when we have an event that happens in a mass gathering or any type of mass casualty incidents. The problem is how deep we go into that emotional basement, where we stay there for a long time, have a lot of kind of negative context, get out of that framework of no ego, no blame, and then also what we do while we're in that metaphorical basement, right? We're probably not making good planning assumptions, we're probably not leaning above and beyond in terms of connectivity. And that's actually where I think in terms of leadership in mass gatherings, we can potentially really get stuck. I think for all mass gatherings, we really need to think about a context of what if. I would have never thought that we would have a bombing in an area of the Boston Marathon. It was not kind of in that context. But I think that has really kind of changed a little bit of our long view as we start to shift in that long view of what all the other hazards and all the other potentials are for mass gatherings. Thank you.
Thank you, Prof. Tahir, and we will move forward and we'll keep the question at the end. Our second speaker is Dr. Hamad Al-Rumehi. Dr. Al-Rumehi is a senior consultant community medicine. He is the director of the Health Protection and Communicable Disease Control Department at the Ministry of Public Health in Qatar. Dr. Rumehi received his MD from the Arabian Gulf University Medical College, Manama, Kingdom of Bahrain. And he's a Arab Board Community Medicine Training in Qatar and a Fellowship of Faculty of Travel Medicine from the Royal College of Physician and Surgeon of Glasgow. He will be talking about the World Cup in Qatar. Please join me to welcome Dr. Rumehi.
Thank you, Dr. Ali. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon to you all. It's a great honor for me to speak to you here today. And I would like to thank the Dr. Anas Khan and the organizing committee for this invaluable opportunity to speak about Qatar experience, Qatar FIFA 2022 experience, and briefly highlight some of the lessons learned from the tournament. I would like to start my presentation with a quote from His Highness Sheikh Tamim bin Hamad Al Thani, Emir of the State of Qatar. We have fulfilled our promise to organize an exceptional championship by Arab countries, which provided an opportunity for the people of the world to learn about the richness of our culture and the originality of our values. Everyone agrees that Qatar fulfilled its promise for this World Cup to be an exceptional and historical edition whose impact and legacy will remain throughout history. Many sectors across Qatar have played an important role in the tournament success, and as a healthcare sector, we have been at the forefront of these efforts by delivering one of the healthiest and safest World Cup ever in the history. This slide displays the journey of the FIFA World Cup 2022, how a dream was born 12 years ago. With hard work, dedication, and attention to the simplest details, Qatar believed in its promise to give the world best ever World Cup, and it did. Multi-sectoral collaboration is paramount importance in hosting mega sport event, mass gathering, to effectively mitigate potential health risks. Ministry of Public Health worked in cooperation with local healthcare institutions and international partners to develop our plans to healthcare services and response to public health incidents. One of the most important success factors for healthcare delivery during the tournament is the integrated health sector command and control system. With robust governance structure, successful collaboration with other sectors, empowered command group chairs with clear mandate and timelines for delivery to ensure an exceptional healthcare experience to fans, players, residents, and visitors. Healthy FIFA World Cup 2022, we are very proud about this project with the World Health Organization, in partnership with World Health Organization, to deliver a 3 years program creating legacy for sport and health. And the ultimate goal from this partnership with WHO is not only to serve Qatar during the World Cup, but also to create a sustainable, long-lasting model promoting integration of health security and well-being for future mega sport events. As you can see in this slide, there are 3 pillars for this initiative: health promotion, health security, and health communication. Health promotion focus on promoting physical activity, healthy diet, tobacco control, and mental health. Health security focus on safety of mass gathering for fans, players, and staff. And health communication focus on disseminating messages and campaigns for health and safety. And here we'll show you some of the examples and initiatives of this pillars. For the health promotion pillar, as you can see here, a promotion of physical activity to promote international knowledge transfer and strengthen local policy and practice. Sport of Health Conference organized in 2022 in collaboration with WISH. Also, a promotion of nutrition. Qatar, also the Ministry of Public Health, published guidelines for healthy food during the mega sport event, during the World Cup. And during this tournament, we offer 30% healthy option in the stadiums and 21% healthy food option in FIFA fan stadium. Also, this guideline shared with WHO, and it's published for a future mega sport event. Tobacco and smoking cessation, banning of tobacco and cigarette in the stadiums, ensuring fans enjoyed smoke-free air while watching matches. Here also you can see in this initiative the mental health awareness. Sheikh Hind bin Hamad Al-Thani, the CEO of Qatar Foundation, and here the popular athlete Mo Farah. This initiative launched during the World Cup with the project of physical activity friendship bench. This bench are distributed in all stadiums, like 32 bench and it demonstrates the significance of mental health being through physical activity and sport. With regard to the health security initiative, this is also another important pillar for to secure the public health, and so during in this initiative, we have different projects and plan, including the epidemic intelligence from open sources. This is also an initiative in collaboration with WHO. It helps us to detect any like rumors or any news through the social media or through the mass media. Also, we launched different plans for health protection, including plans for communicable disease control and environmental health, and to enhance our surveillance and certain protocol for event-based surveillance. In health communication initiative, we utilize different tools like artificial intelligence, the WHO Florence digital health workers, to provide guidance on certain areas, especially for tobacco control and some healthy awareness messages. Also, we hosted a Walk the Talk initiative during 2022 in November, one day before the tournament, to encourage physical activity and to promote healthy, sustainable future. And during this event, many popular athletes like Muktasbat and also international athletes like Didier Drogba, Her Excellency the Minister of Health, also His Excellency Dr. Tedros, and also His Excellency Dr. Ahmed Al-Mandari, the regional WHO director, participated in this event. As I mentioned, also the engagement of ambassadors from FIFA World Cup and to Team Up for Health for All campaign. WHO mission, we would like to thank WHO for their support during this tournament. In addition to the project Sport for Health, also they provide different technical missions before the tournament, including COVID-19 risk assessment, zoonotic diseases mission, acute flaccid paralysis to update our plans, food safety mission to update our food security plans, food safety, and also monitoring of food during the tournament. Also, we have conducted the after-action review to document the best practices and lessons learned from this tournament. Also, we updated our measles outbreak plan in case of if there is any cases or imported cases of measles. As I mentioned, also epidemic intelligence from open sources. This is like initiative. We already did it with WHO, and it helped us to track any alert or event in different media platforms. Exceptional healthcare delivery. The provision of healthcare services during the tournament involved a range of planning and preparations, including modeling to anticipate demand, identification of existing capacities, prioritization of medication supply, and workforce planning. The healthcare was expanded to meet the additional demand of 1.5 million visitors during the tournament. As you can see here, more than 51,000 fans were treated during the tournament. Most of them, they received like treatment for minor injuries or like minor symptoms like common cold. And here, the slide illustrates show that 0.1 of them were admitted to hospital. So this is very low number of fans. 2% of them were transferred to the hospitals, and more than 33,600 fans managed at competition and non-competition sites. More than 6,000 fans utilized the urgent care walk-in clinic. There were like dedicated health centers and hospitals for to cover the fans during the tournament, and more than 4,000 were treated in health center also. More than 4,000 related calls to the ambulance services, sorry. Also, workforce and logistic hub were set up to where staff redeployed across the sector, central scheduling and dedicated competition and competition site teams, with other also services like, for example, the language bank. This is also a service to deal with any calls and from different fans or people, visitors in the country. Here also enhancement of the Ministry of Public Health teams. As you can see, there are enhancement for certain teams, like enhancement for emergency preparedness and response. We developed the contingency plan, we update this plan, we conduct national risk assessment using WHO tool, STAR tool, strategic tool for assessing risk. Also implement wide variety of training and simulation exercises. The staff, they receive different trainings to cover the training site, competition site, especially the nurses covering the services outside the hospital. Also, we established the Public Health Emergency Operation Room. This is in the Ministry of Public Health to deal with any public health threats and risks. Also, as you can see, our national team participated in the national exercise led by His Excellency Sheikh Khalifa bin Hamad Al Thani, the Chief Operation of the FIFA World Cup. And this is was important for our team to test our readiness, to make sure that we are ready for the tournament and to find any gaps before the tournament, and to ensure proper coordination with other sectors. With regard to health protection enhancement, to reduce the risk of alcohol-related disorder, such as violent behavior, MOBH ensured implementing the following: alcohol ban policy inside the FIFA-related stadium, and thus was announced just before the tournament, and the provision of sobering station for FIFA to recover from the effect of alcohol intoxication. Also, we did enhancement for our surveillance team. We updated more than 35 plans and guidelines mainly for the public health and for communicable diseases. And also, we have different, we redeployed our public health teams to all the, stadiums as active surveillance officer to monitor the public health risk, and also to early report any incidents. Also, for surveillance, we have identified 13 national priority diseases just for enhanced surveillance during the tournament, and we focus mainly on diseases that might transmit during mass gathering, like disease, respiratory infection, fever and rash, and other diseases like foodborne diseases. And we monitor some important risk like COVID-19. During the pandemic, it was during the pandemic, so we are monitoring the situation of COVID-19, and we are also monitoring the SARI, the severe acute respiratory diseases. Also, we implemented like a syndromic surveillance, and this is as agreed with WHO for certain disease to make our surveillance more sensitive. I need to go fast because of the time limit. This is, I think, important. I need to highlight it quickly. This is one of the challenges during the tournament, that rumors usually, even if there is no any cases, it's usually it's easy to be to cause some attention by the media and some by the community. So with the help of the epidemic intelligence from open sources and also from media department, we detect this rumor early about MERS-CoV, and we verify that there are no any cases of MERS-CoV during the pandemic, but the media try to like make it يعني a big concern for them. So I need to skip some slides for the time limit. I need to go to the I want to highlight some of the lessons learned from this pandemic, from this tournament. One of the important lessons learned, I think, from this tournament is the strong political dedication to deliver an exceptional World Cup experience. This has helped us to deliver this because with a clear mandate, with being on top on all operations, this has helped all the team to identify and to allocate the resources and to reach our target. Also, all hazard preparedness approach to test emergency plan. This is very important, not to focus on one area, but also to implement all hazard approach in preparing for the mass gathering event. Also, for the public health area, we received international accreditation from FAB. It is Public Health Accreditation Board, just maybe around 2 months before the tournament. So it's always mass gathering is opportunity for public health to be strengthened, to be ready for the future. And we took it as like a privilege for us to take this accreditation because we do everything to make the public health ready for the World Cup. So we believe that we have all the capacity to be accredited. So, and it is also giving a trust for the community, from the community that that the public health will implement the best practices. Also, IHR capacity is, I think, very important, and we followed the key consideration from for hosting a mass gathering, WHO manual. This was very important, and it's really helped us to improve our core capacities. Also, here I think the building on past experience. This is very important for us. With WHO, we get a lot of this is the legacy from the previous tournament. That's why we stress on the importance of legacy. Legacy is important because it will also benefit people preparing for the future mass gathering. Here also the demand modeling anticipate resources. This is very important, and we learned this from, I think we get benefit from COVID. I know it's costly benefit, but I think COVID helped us a lot, that we learned how to anticipate for demand. We work more on modeling. So we adopt the same model here for the World Cup to anticipate the demand for the health sector, the need. And this is, I think, very important for any institute preparing for the huge mass gathering. Future recommendation, also I want to summarize them. I will not go in details, but in summary, I believe that the legacy of the FIFA World Cup should be shared widely to the benefit of the future mass gathering. Invest in innovation, including wastewater surveillance. We adopt a wastewater surveillance in the FIFA World Cup. It helped us a lot in COVID-19 and polio. I think this is very important now because for COVID-19 is not anymore people coming and do the testing. So wastewater is the early alarm for any emerging infectious disease. Also, ensure a single source of high quality data. So I think we need to invest more in high quality data. This will help us to have a data-driven decision. Last point, to invest in stronger and more resilient, flexible healthcare system, so it can be flexible to expand and shrink if it's required, to have the surge capacity for any future event or even any emergencies. Thank you for listening.
Thank you, Dr. Hamad and Dr. Sofia, for a very interesting talk. And our session will continue with more even interesting topic, and I hope you will enjoy the next coming part of this. Our next speaker will be Dr. Eric Review. He's an emergency physician and toxicologist. He's the head of emergency department and pre-hospital medical service at La Ripollère Hospital in Paris, France. It's chair of pre-hospital section in European Society of Emergency Medicine, and also he's the scientific committee of French National Society of Emergency Medicine. Dr. Eric, he was the co-chair of clinical practice committee of the International Federation of Emergency Medicine, and he's an editorial board also in two of the very distinguished journal, Turkish Journal of Emergency Medicine and Canadian Journal of Emergency Medicine. He will talk about Paris SAMO event, and I hope you'll enjoy this talk. Please help me welcome Dr. Eric.
Assalamu alaikum. It's a great pleasure, great honor to participate. I would like to thank the organizing committee to this very kind invitation, particularly Dr. Anas Khan. It's very nice for all of your invitation. Let's talk about the thing. I remember 5 years ago, it was in 2015, I was at home watching the football match, France against Germany. We won the match, but nobody cares. And then I have a phone call from the SAMU, and they say, I don't know what happened. We have a bombing in this stadium. Send all the team you have because we need backup. It was really the first time we had to fight this kind of terrorist event. 5 years later, during the COVID, we fight, all of us, the COVID. I remember I had a phone call also. It was a Sunday. We had to meet, all of us. It was a Sunday. I'll never forget that. And all the ED and French SAMU and the EMS and emergency department were discussing about the situation. We had no idea about what's coming. The only information we had coming from Italy, from Lombardy, they said, I always remember, an emergency physician in Italy said, I have 2 patients to intubate. I have just 1 ventilator. I have to choose who I need to intubate. This kind of first information we have to organize. That's when we start. We knew that we had 2 weeks to prepare before the COVID coming. So what's the connection between the terrorist event and the COVID period? We know all the disaster principle. We know that we have to prepare all the time. EMS, disaster medicine, we have to prepare for the unpredictable event. So that's the thing we try to always to work, to prepare, and to organize. That's the basic thing of emergency medicine and pre-hospital and disaster medicine. But it's not enough. We are not very fortunate. We have a long story in France of terrorist events. Long story. Since the 1970s, we had a lot of terrorist events, bombing, shooting, a lot of things. But the worst happened in 2015. It was the first time, and we hope the last time, that we have a lot of patients who just came in our disaster plan and came in emergency department. We had hundreds of patients coming with different countries were in Paris. You have heard about the Bataclan, but it was not the only things that happened. Thanks to Pierre Carly, here's the map of Paris, beautiful city. And Pierre Carly, the head of the SAMU of Paris, decides a pre-plan to share Paris in 3 parts. North of Paris is in charge of the SAMU of Paris, west part, inside Paris, and in the east part. The north of Paris, outside of the frontier, it could be the frontier, it's another SAMU. And that's where the Stade de France, the stadium, is there. The first bombing attempt was outside of Paris. And the first deal, the first bet that Pierre Carly, the head of the SAMU Paris, he said, don't send all the MS on the same place at the same time. Why? It's because we had information that we could have a terrorist attack in different places. We call it the multi-site event. That's why he just sent a few team and said, wait, we don't know what happened. He was quite clever because a couple of minutes later, we have the shooting, terrorist shooting in the street of Paris, in the restaurant. And a few minutes later, we have the Bataclan concert hall when we have the shooters inside the Bataclan hall. So 3 different sites. The pre-plan by Pierre Carly was the camembert, famous cheese we had, and we call it, prepared this plan before it happened. That's exactly what happened during the terrorist event. A few minutes after the first explosion, we had the second one and the third. We were lucky. Why? Because the terrorists just had the vests and the bombing. They couldn't come inside the stadium. Can you imagine what happened if they come inside the stadium? They couldn't come because the security guard just can't stop them. So that explodes outside, so that we didn't have a lot of victims. But the first bet was to send just a few EMT on the scene. And as you see, 5 minutes later, it was the second group of terrorists inside the street of Paris, shooting, and then we have the Bataclan. This kind of plan, that's decided to send the EMT. Also, you have a lot of patients walking patients coming on the nearest emergency department. And we send all the EMS to try to plan to remove those patients. We call it the Alpha Red plan. Usually when you have this kind of situation, you make a triage on the scene, fast triage, and you send the patient and you separate patient, urgent, non-urgent patients. The Alpha Red plans, due to the fact that we have to train, is to remove the most injured patient outside of the scene and goes directly to the OR because the surgeon will save the patient, not us. We have to move there very quickly. That's exactly the principle. It was not medicine, it's more military medicine, it's tactical combat casualty care. So that's the thing we have learned is to control hemorrhage. The only thing you will have to do using tourniquet, don't just maintain blood pressure, put tranexamic acid, control hypothermia, give oxygen, avoid, if you can, to intubate the patient, and go directly in less than an hour to the nearest hospital. Not the nearest, but the predetermined hospital just have to wait for you. So that's the main principle we have to use during this first terrorist event. And it works. Many times we've used this system and maybe we saved some life there. But a lot of people anyway could die because they have a very severe injured lesions. First feedback experience we had for that, what was? They have good points and have bad points. The good point, this Alpha Red plan activation was really easy to activate it very quickly. First, triage and BLS, very basic life support on the scene. Don't lose time and bring the patient. It was an efficient damage control, very quick evacuation without any discussion to move those patients. The thing is, we use radio. Why? Because the cell phone didn't work, and calling the dispatch took time. That's a bad point that we have to change our procedure for that. And we had to use the hospital resources that the pre-plan, that it was done, to use what kind of hospital we use. We were closely working with the first responders in Paris. They are military. It was really helpful. And we have to work also with the SWAT because the SWAT team with the doctor inside were inside the Bataclan. So that was the first thing we've learned about that. Bad thing we have to change is identification of victims. It was not easy to do, and we made a lot of mistakes for that. And maybe to secure the zone. One of the things we have learned is to send an EMT on a not a safe zone when the terrorists are still shooting is dangerous for your team. It's really dangerous for them, so don't send the team on a safe place. So we've learned about that, so we reorganize now our system just with this alert. Call a backup team, yeah. all of us, like me, we were on TV. You don't have to call me because I know that anything happened in my ED. So a lot of us came in. But the thing is, we've had to learn. It's just happened in one day. So the thing is, you have to think about this other team you have the day after and the day after and the day after. You cannot use the same. And we have to change, we had to change the organization for that because they will feel bad not being on the scene the same day. So the turnover rotation was one of the main things we try to fix now and to reorganize. And then we have to train because it's a military medicine, so we have to train now. And we train with police, SWAT, first responders, secret services, because we need to have the information. After the terrorist event, we had another information from the secret services, and they said, be careful. Now they know where your weaknesses are. You know that schools, hospitals are the weakness of your system. Be careful. So that's why we had to train a different way, and we try to update our plan. The key point from Paris attacks, it's military medicine. It's not usually the medicine we've used. So safety, it's the first thing, safety only for your team also. So don't lose time. The thing is, we have a very strong system, yes, but don't spend all the time on the scene if the patient is really a severe condition. So damage control resuscitation and move the patient in less than an hour to the OR. We have the ECMO team. That's a very effective team that we use. This team, that's the Louvre, that's a real picture about the ECMO. We do ECMO on the scene, outside of in the street, outside of the hospital. This team is dedicated only for cardiac arrest. This expertise that we have using with this team is really a 24 hours team that work inside Paris, and we do have the same. How we can use it. This is the real pictures about how we use the ECMO team in the metro outside of Paris, and we have some criteria for activation of this ECMO team. Not all the cardiac arrest had an ECMO team that had to be activated, so we have this kind of refractory cardiac arrest, starting CPR within a witness in the first 5 minutes, and a shockable rhythm. So that's the thing, if we have this ECMO team ready to do use, and we work together with them. Okay, the thing is, we've used the same ECMO team in our system during the COVID. Coming to the COVID, yes, we have a long story of using a train to transport patients. Why? It's very easy. If you want to transport a lot of patients in 1,000 patients in the same time, you use a train. Very easy. Well, in France, when we are not on strike, it could be okay. But we can use it. So the TGV can work. And we have planned and organized the TGV to transport patients for a terrorist event. But during the COVID, we've used the same. The principle we've done, so we've used the TGV the same way, using the EMS to transport patients from an ICU to another one. Why we have done that? Because it was the mess everywhere, so we have to change, and it was the mess in many ICU, particularly in the different regions, and we have to move patients from an ICU to another one. So that's the thing we have used in the train. In the train is remove all the patients from some ICU, only COVID patient in severe condition. Some of them all the patients were intubated and transported by train from a region to another one. It was very useful because all the region, particularly the north of France, were overcrowded, particularly the ICU. So we had to remove those patients outside to let them keep the patient in the same way. And we have used the thing. We first consummated our organization for the management of patients. So all the TGV were used to transport patients. It was really to prepare, we have an ICU dedicated room, and we have another organization to manage the patients. But we've done the same with the plane when we are not on strike also. That's the same. we've used the experience we had for the train for the plane, because we had a lot of French region in Ireland, Pacific Island, New Caledonia, Tahiti Island, La Réunion, Guyana. Those islands really have poor resources, so that's why we had to remove those patients outside in the same way. Same organization, but a very strong organization, because taking a plane. That was the first. We were very proud of that, because it was really a strong organization, because we use regular flight, not military flight, to transport patients. One of the problem was oxygen, electricity, and you need to have ICU doctors and emergency physician, high-trained doctors to manage ventilated patients in the same way. So one of the take-home message for that, of course, we need to be prepared. So we need to plan that way for a potential threat we could have. Timely response, it's one of the things we've learned from the terrorist events. Experiment in new protocol, new procedure. We need to experiment new procedure. That's what we have done. Preparation is very useful to do that. Alerts and electronic surveillance, real-time communication system and response team. So we have and evaluate and drill. That's the most thing. The same day of the terrorist event, the same day in the morning, we had a drill on the same scenario. And when it was over, we called the doctor and say, okay, the drill is finished. No, it's for real for now. And the first conclusion, it's a really basic treatment of injuries. We need to first evaluation of the scene to all the patient, be ready for that recognition of what kind of chemical or different attack you have. Look at for EMS and resources to remove those patients and anticipate the thing and control the injuries. That's the basic thing you have to do on the scene. So mass gathering medicine is really adaptation to all the situation. From the terrorist event to the COVID, we had to adapt. Adaptation is not improvisation. We need to train, we need to practice, we need to evaluate the thing. And the thing, our role is to manage and to bring a lot of patients alive to the surgeons. So we need to train, simulation, and it's a great pleasure to share with you this kind of experience. Last but not least, it's playing chess. Playing chess is to have to move forward. You have to think before the other. That's why you can win the game. Thank you.
Thank you, Dr. Eric, for this interesting talk and for sharing your experience. We'll go on, and for our next speaker, Dr. Saad Ali Al-Asiri. Dr. Saad is an emergency medical consultant. He's a certified emergency department executive from Harvard University with Master Science in Health Administration from Walden University, USA. Dr. Saad also is a medical education certified from McMaster University, Canada. He's one of the pioneer leaders in the transformation of healthcare sector in the country. He has many transformational projects, and he's high-profile emergency healthcare initiative. Currently, he's the regional director of emergency department in Salman Al-Habib Hospital in the Gulf region. Please help me welcome Dr. Saad.
Thank you so much, Dr. Mohammed, Dr. Ali, and the rest of the team. All the audience, good afternoon. It is my pleasure to be here with you today. I would like also to start by thanking Dr. Anas Khan and his team for conducting this amazing international conference, and at the same time to give me this opportunity to be here with you. So we're going to go and talk about different topic, which is local and national topic, which is about covering the entertainment from health perspective. Now the question, what we are doing as a private sector. We are actually giving the healthcare, we are doing also health education, and at the same time offering different levels of patient care in the field outside the hospital. And this is of course actually in collaboration with all the stakeholders. Now the question, which is very important, why we do it? We do it for many reasons. Number one, as part of the vision for 2030, which is actually empowering the private sector in the healthcare system, and at the same time, which is actually creating strong link and strong collaboration between governmental and private sector. And one of the things which is actually as very strong statement from the Minister of Health yesterday, which is actually the future for the healthcare system from private perspective, and that strong interaction and the growth coming. So we are part of that future, and this is actually going live currently, and this is what we are practicing. Number two, which is to give the best patient care for our patients in the field. Always our patients, when they are actually in the entertainment, any kind of events, which is a sport, different types of events, there are many things can happen for the visitors or for the organizers or for those participating. So we offer them the best patient care to give the security, which is health security in these events. Number three, it is actually very honor for us as a medical group or for us as medical team to participate in such big national events, which is representing our country, and we feel proud to be there and to represent our country in the best way. Number four, of course, which is actually from a business perspective, it is a strong marketing, and definitely it will be a positive impact as a return of investment on our business. So the process of operation, which is actually starting by visiting the sites, by doing gathering of data and analyzing those data, meeting with the organizing teams, looking at the site from all aspects and doing actually risk assessment for it. So in such a way we know what kind of event. We are dealing with different events related to the art, to the sport, which is actually all gathering in one thing, which is mass gathering. So mass gathering need actually full risk assessment, and accordingly we put actually what kind of medical teams, what kind of resources we need to put, and what kind of organizing the team between us and the other stakeholders. And this is actually taking our team to the different level, which is gathering these resources, putting actually an urgent care center. Usually there is actually minimum 1 or 2 resuscitation units in the field, and different types of vehicles related to different types of ambulances, emergency golf carts, and of course there will be actually different types of manpower levels. Consultant emergency, specialist of emergency, paramedics, senior level or junior level, and of course nurses. So all of that actually to be gathered, and at the same time we try to make actually all the team in harmony and on the same page. How we do that? By doing the full orientation for each event, what kind of risk we are expecting, doing that workshop before the event, and putting all on the same actually page, and to keep them in very high standard. After that we go to how we connect between the team and the ground, and we connect them to the organizers. Number 2, which is the second level, connecting the people in the field with the other stakeholders outside, which is, for example, Ministry of Health, Disaster Command Center, and the other hospitals, and how we facilitate transferring the patient from the field to the hospital safely. Of course, any work in the field is different from the work in the hospital. A lot of challenges. It is totally different. And really, we like to accept these challenges, and we look for the solutions for it. One of the important challenges, which is actually to make that coordination between us and between all the stakeholders, and there are many stakeholders working in the field, which is related to the organizers, governmental, non-governmental, and how we bring the people to work with us to be in the same page. And this is actually a very important challenge, and always we face it because we are dealing with different sectors, governmental and non-governmental. How we facilitate to move the patient from the field to different hospital, how we facilitate the traffic, and at the same time, how we do the monitoring in the field in collaboration with everybody. The second one, which is actually to keep everybody in the same page. If you want to give the best patient care, you need to give actually what kind of concept and what kind of business, what kind of operation you want to do. So in such a way, they're going to facilitate that for you. Of course, the sudden rush of patients, which is actually a big challenge, and we know it in emergency. When you put actually resources, and after that you find actually a lot of patients or sudden rush of visitors, this is high risk. And this is need actually dynamic operation plan to deal with it very quickly and to solve it. So this is one of the things, usually it is big challenge to facilitate it in different events. For example, in Riyadh season, we have actually more than 12 locations in Riyadh city. How are you going to coordinate the logistics? How you coordinate that with everybody and in different sectors at the same time? Now, this is really big challenge. But with the spirit of the teamwork, we achieved that. Too many different variety of events. One day you are dealing with sport, second day you are dealing with concert, third day you are dealing with different entity, and of course, different type of population, adults, pediatrics, athletes, etc. So every single event, there are different preparation for it and different resources and different concepts. Of course, all type population, all type of age, all type of emergency cases from level 1 to level 5. And this is actually a big challenge because you need to be ready for those cases and to deal with it. This is one of the examples. This is one of the big concerts happened. And if you look actually the stage, which is actually in front of us and in the sides, there are actually the seats and a lot of standing people in the middle. Now this hundreds of thousands of people in the middle, how you gonna to coordinate with everybody, the traffic, how you extract patient from the middle of the crowd, and you keep your staff safely, and you transfer those patients to a secure and safe place to treat. Which one you gonna to decide to transfer to the hospital? So this is one of the challenging events, which is actually now in our country, it is actually frequently happening. So if you have actually the proper resources, the good concept about it, and how you coordinate properly and you keep the good communication inside this huge crowd, you can actually control it in a proper way and you keep everybody safe. One of the challenges usually we face it when you are dealing with patients in very crowded place. So usually using the emergency golf is very helpful. The same thing, which is actually treating them in the same location, and after that you discharge them. Another challenge, usually we see it because now our country is open for different countries, so which is actually sometimes the language barrier for some of the nationalities which we face, or they don't actually have all the details about their past medical history, or they don't offer us any information, and this is also another challenge. But even though our medical team now, they have actually all the capabilities to deal with such actually big challenges. So what are the results when you start to prepare all of that? You do the analysis and you prepare for the event very well, and you start to control it with good communication with everyone. Over the last 4 years, since 2019, since we start to work in the field and to work with different actually sectors, it was more than 30 million visitors, and we treated more than 80,000 patients. And with the transfer to the hospital, less than 1%. We treated in the same location more than 99%. So this is actually a huge number when you are dealing with such variety of cases and big number of cases. And the results for that, because of the strong preparation and the strong actually planning, especially when you are covering from coast to coast, I mean inside the country, which is actually all different cities, which is we covered more than 60 events with different types. Some of it actually mega events, and I'm gonna to give you some of the names of these mega events. Different types of age, of course, the age group, which is actually the healthy young people, but they are associated with many injuries because of their activities, the kind of the sports, and this is actually a very important part we have to consider. Of course, actually, the nationalities, the majority of the nationalities Saudi. Of course, we have actually a big number of nationalities, more than 30,000 non-Saudi coming as tourists coming from outside the country. And this is actually something we need to consider because we have to consider what kind of past medical history with them. Procedures, more than 10,000, and procedures I'm mentioning actually all type of procedure you can imagine. We dealt with cardiac arrest, intubating patients in the field, defibrillating patient. Of course, sometimes patient need tension pneumothorax. You have to start by decompress it and putting just a tube. Don't think we are dealing with the majority stable cases. No, we dealt with huge number of cases which is actually unstable, and we have to stabilize in the beginning, and after that we send. But how you stabilize if you don't have the proper resources? This is why I mentioned, I put the picture there. It is urgent care center with resuscitation unit with full capabilities to deal from level 1 to level 5, including life-threatening conditions. And of course, part of it, when you do that, those procedures for the patient, we send the patient with full medical team in facilitation between our command center with the command center of the Red Crescent or the MOH to facilitate also the transfer. We transfer the cases to other hospitals or our hospitals with full safe business module with high qualified physicians and nurses and paramedics after stabilization. Now the referral, which is actually, I consider it amazing number, 107, only out of more than 80,000 patients. And this is a very clear indication what kind of resources and capabilities is there. So this kind of new business module, we reached to actually that before because of the good number of manpower, which is actually different types of physicians, nurses, paramedics, and of course all types of vehicles we use, starting from ambulance type 1 until type 2. And of course, there are a lot of logistics and supportive team behind the medical team because it is teamwork and a lot of resources we have to put it in the field. We are proud by those partners. We are proud as a group to participate in mega events like Hajj, Riyadh season, all Virgins, also in Formula 1, Ministry of Defense, a lot of events. And in every single event, there are different types of actually business module, different type of operation, and business type that need actually good planning and amazing resources to be gathered with a strong team. So actually, it is not typical from event to event. It depends on what kind of assessment and analysis we do. Because of that, and because of the results which I showed you, we gain the trust from actually different sectors, governmental, non-governmental. This is why we have this huge number on those two slides, which I'm presenting now for our partners, which is actually indicating how strong that type of business and this new modality of covering the entertainment by a new concept to give the safety and healthcare sector and entertainment. And this is really matching the goals of Vision 2030. And what's the benefit of that? Uplifting of the healthcare operation in the field and a new concept. We are proud to present it in our country, and actually we feel proud to share it with everyone in this conference and to represent Saudi Arabia from this perspective as a different concept. And at the same time, this is matching what mentioned before by the strong integration between the private and the governmental sectors, and hopefully we're going to continue in this more and more. Thank you so much.
Thank you, Dr. Saad, for this interesting talk. For the sake of time, we'll move on to the next session. Our last speaker for this session will be Dr. Derek Tin. He's a faculty at Beth Israel Medical Center and Harvard Medical School Disaster Medicine Fellowship. He's an associate professor in critical care medicine at Melbourne University and sits on the board director of the World Association for Disaster and Emergency Medicine. Please join me, welcome Dr. Derek.
Right, thank you everyone for being here today, and thank you Dr. Anas Khan for inviting me to your beautiful country. My name's Derek Tin. I'm a disaster medicine specialist and a critical care doctor. I've got operational experience in both natural as well as man-made disasters. I've deployed to run field hospitals, doing maritime rescues, and other humanitarian events. And over time, I've really sort of developed an interest in how man-made intentional events can impact population health. At a very basic level, many split disasters into natural versus man-made, but of course, we know that distinction is not that clear. Take global warming as an example, what many consider to be a natural phenomenon. There is robust scientific consensus that our actions today are leading to many of the climate disasters we are seeing, and that disasters are in fact a construct of poor preparedness. There is now research into how climate change is fueling terrorism, an area of specific interest to me. And as we know, terrorism and humanitarian crises often also go hand in hand. And when you start studying disaster medicine, you quickly sort of realize the complex relationships between everything happening around the world. I'm especially interested in the climate, security, terrorism nexus and how that impacts population health. But ultimately, whether this is a weather event, a terrorist attack, a refugee crisis, this all really converges back to what we do as disaster medicine specialists. We look after the people that are affected en masse. We look at how the systems can support these sorts of disasters, and we lead organizations through the crises they face. And this is essentially many of the same goals mass gathering medicine attempts to achieve. And whilst there's no real consensus on the exact definition of what constitutes a mass gathering, there is consensus that it covers sporting, social, cultural, religious, and political events, such as political rallies. And part of what we do in DM and CTM, counterterrorism medicine, is really look at modern societal trends, emerging technologies, and geopolitical events, and try and anticipate what unforeseen harm could be inflicted on the masses. We published this paper on the stadium disasters a few weeks ago, and in all our papers, there is always an angle of intentional threat. We argue that stadium events are very attractive terrorist targets, and there needs to be better understanding of what that means from a health and security perspective. I personally find it quite interesting that political rallies fall under the scope of mass gathering medicine, because I would say today they should be considered a fairly unique, risky security event and are significantly more complex than your other more traditional mass gathering events. And we've seen that after the January 6th Capitol riots, where significant domestic terrorism charges have since been laid. And if you tell me, well, that was an extreme example of a political rally, well, trust me, I can pull out many examples of others where violence was really on the cards and ended with deadly outcomes all around the world. I can pull out hundreds of intentional attacks against concerts and festivals. And by the way, I wrote this long before the events of October 7th. I can show you thousands more of attacks against mass transit systems, and thousands more against religious figures and institutions in the report we are about to publish. But regardless of categories and definitions, my question to you as mass gathering expert is, how much do you spend analyzing intentional threats at your events? How much do you invest in understanding that? And it's not just a case of getting the security guys to do their security thing. How much do you understand the impact an intentional attack will have on your capacity to respond? How much do you risk analyze the safety impact this has on your medical crew or your medical institution, either as primary targets or as secondary collateral damage? How much do you take intentional attacks into account when you do your hazard vulnerability analysis? How much do you train your guys to provide care in an environment of threat? How much do you inoculate your staff to make them more resilient before a disaster strikes? And what sort of evidence-based psychological support are you going to provide your staff and to victims? What can you do to mitigate some of these risks and be better prepared? These are already core topics in our teaching in our world of counterterrorism medicine, teachings that I believe are important for not just the growth of mass gathering medicine, but for us, given the environment of threat for the civilian sector as well. We looked at, this is some of our research, where we looked at the frequency of intentional attacks across the world and by region. We broke down the weapon types used to better understand what clinically we might be dealing with. We looked at the lethalities of each attack modality and how the death and injury tolls differ in historic events. Of course, we also looked at the traditional WMDs, your chem, bio, rad, and nuclear attacks, and how through our research and discussions with our tactical response and hazmat colleagues, how can we improve their preparedness as well as their response algorithms? We looked at current issues in the US, like the opioid crisis, and how terrorist cells may be able to exploit that to cause mass casualty events. And this paper we wrote with 2 professors in criminology and did a specific look into suicide bombing terrorism to understand why suicide attacks happen and why they kill and injure 10 times more than a conventional explosion. We wrote a recent primer for medical staff on how cyber threats can derail medical systems and what downstream social, financial, psychological, and health impact this can have on the regional population, a topic that is really at the forefront of many societies today. And all this really feeds into what we call hybrid warfare, a mix of conventional and irregular warfare, terrorism, and criminality, using different non-conventional modalities like drone technology, cyber attacks, CBRNE weapons in a civilian setting where you and I now have to, as civilian doctors, deal with the aftermath. These concepts are not new, but the speed of the development is outpacing our understanding and research on the health impacts they have. And unfortunately for us, we get caught up with all of this. And if we don't start at least understanding the impact these events can have on population health, we can't possibly begin to mitigate these risks or respond to these events. In the last 2-3 years, we've published numerous papers on these topics. But we're not just going to do some academic high five and leave it at that. I'm a boots on ground kind of person and really about translating some of the academic work into operational changes. We run a pre-deployment course for our fellows and put them through fairly realistic hostile checkpoints and physically and psychologically stress them out as they are trying to achieve their mission goals. We specifically train our guys in tactical emergency casualty care and how to operate in an austere and high-threat environment, how to prioritize medical care based on the threat situation. And we run an in-house lecture series. From a clinical perspective, we lecture around the differences between an accidental explosion versus terrorist bombing and try and understand why the injury patterns are so different, so much more devastating. We try and understand best practice algorithms after a suicide bombing attack in terms of viral or bacterial prophylaxis if there is foreign body tissue implantation in the victims. We look at trauma patterns of terrorism versus non-terrorism injuries to understand how we can prepare our ED slightly better in case this happens. We also specifically look at how vulnerable populations, such as children, are differently affected in terrorism-related injuries from a clinical perspective, but also discuss the broader psychosocial impact these events have in the long run. We wrote this recently about the need to understand how media bias can significantly influence aid, something that is also being played out today on our screens. And we have a mini-series coming out on conflict and health, which I hope many will find interesting and is certainly very topical and relevant today. For those interested, the World Association of Disaster and Emergency Medicine has a special interest group in counterterrorism medicine. I also run, myself and Professor Siotone run a CTM LinkedIn group online. And I really hope my talk sort of gave you a glimpse of what we do as disaster medicine specialists and in our work in counterterrorism medicine. And I hope we can exchange some of the lessons learned in our respective field to improve health and security for all. Thank you.
Thank you, Dr. Derek, for this interesting talk. And I think we reached to the end of our session, and we'll have time for 2 questions. So please. سؤال واحد. أبشر. أنت المدير، إحنا نقول أنت تأشر وإحنا أسمعك أبو نور، تقدر ترفع صوتك.
Very hearable. Thank you very much for the panelists, very interesting presentations. So my question will be to Dr. Eric. Very interesting experience, especially in the ECMO. My question is that in the context of rapid onset event, so how would you suggest balancing the imperative to sustain ECMO service for critically ill patient and the immediate demand for large-scale emergency event as such? And what strategies can we employ to make sure that both demands are effectively met? Thank you very much.
Thank you. Thank you for a quick question. Can you hear me? Yeah. One of the things is we try to use the ECMO team as usual daily. We have the activated ECMO team. In Paris, we do for just 1 patient. But in the situation of the COVID, we do train, we didn't have to use it, but we trained by simulation inside the train to see if we could have to use the ECMO team inside. So we activate the ECMO team during the transportation, but we didn't have to use. One of the difficult questions of the ECMO team is the results. We could have lots of I think, bad feedback about the colleagues say, why we do that? The thing is, we've learned to use the ECMO team because before we didn't have, the patient had no chance. So one of the questions we could deal with that is, it's happened in Paris, is to move the patient or to have the ECMO team on the scene, or to bring the patient on the emergency department or intensive care unit in this situation and having the ECMO. We do the both. So it depends really on the situation you're dealing with. So that's why we still have the same team. We don't really convinced to use always the ECMO team outside of hospital because we can lose time. Sometime, and we do it, we bring the patient inside the ICU, and that's the same way we work.
Thank you. Firstly, thank you to the panel for those excellent presentations. And Dr. Tin, I already thought that my reading list was extensive, but thanks for all the paper suggestions. My question is for you. You mentioned threat inoculation for staff deploying in the field. I'm interested to understand how that pairs with the debriefing that you give your clinical staff or all your staff, and how that informs your pre-deployment training. Like, how do you manage that cycle?
Hi, can you hear me? Thanks for that. I think the old debrief has been shown to do nothing at best, and at times can actually cause harm. So I think we sort of go with the psychological first aid at the moment, but if you've ever done it, you realize it's pretty shallow. And the evidence behind that is still scarce. And I think it's difficult because we don't want to cause harm, but yet we don't know where the balance lies. You know, it's going to be somewhere between the spectrum of a debrief and psychological first aid, probably. And the issue with all these are hard studies to do because gathering data in these settings are difficult.
And if I may, with a follow-up, is there a role for decompression for your staff in the way that the certain militaries, international military forces are using, sort of having that shoulder period between the high-intensity operation and returning back to normal life?
Yeah, I think there's certainly, I think a lot of things still not done very well. So if you look at the military, that's a very good example. You know, when we join the army, you get screened. You get a psychological screening, you get all your deployment history done to identify any risk. You know, you've got any previous history of mental health, depression, etc. Yet in medicine, we don't do that. In COVID, we never did that. So already, instead of trying to respond post-trauma, we're actually not really screening our staff. We're just throwing them into the deep end. Imagine doing that with the military. Imagine the harm that will cause. And so you draw very good parallels. And I've always been campaigning to say, well, if I'm going to send my medical staff into an austere high-risk environment, I need to know what the pre-deployment risks are and control that. The peri-deployment risks we can also analyze. As you said, we can actually limit the exposure time. We can't control the amount of trauma they see, the intensity of trauma, but we can limit the exposure time. We can look at the initial reactions, because I know if you and I deploy and on day one I react really poorly, we already know through research that my likelihood of developing PTSD down the line is going to be much higher. And yet none of this is done, right? And we never did this during COVID, we still don't do it today, and I think there really needs to be better understanding and education around this topic.
Thank you very much, our speaker. Thanks, Dr. Ali, also for joining me at this moderation. And our speaker will be available, our panel will be available here for any question if you want to ask later. But for the sake of time, we reached to the end of our session. Thank you very much.
Thank you, dear panel. So we will have a quick honoring the panel, and then we will be having the final session of the day on the big room, a joint session. We will have Dr. Mahmoud Khan, who is one of the pioneers in healthcare field globally. He will be hosting one of the leaders, many of the leaders of the pandemic, but who were part of our scientific committee but couldn't come physically for different reasons. So we will do a Zoom session with them about the pandemic preparedness lessons learned. So please, after this session, you can join us immediately there. Thank you, everyone.